went by. Go ahead.
Well, welcome back, the brave souls who've made it back for round 2 to see what else happens. I think they're cueing a few second clip of night fever if the lights go off again. So we can go from there. See. Yes, sir. Are you raising your hand for a question? So the Orange County example was of Saving Innocence for the CSA advocacy program. They've helped us to implement that. But as far as working with other states, there's quite a bit of activity going on with the First Ladies conferences, the first spouses of most of the governors from the United States, and especially Louisiana, Texas, New Mexico, several of the others here along the southern area have been having conferences to rally their states to actions similar to what we've been able to implement. We are very, very fortunate that it sits in the office of the governor and gives us a purview over the state systems and integration of this into many, many spaces. And I think that the other states that have been asking us about our model, asking us how we're doing with this, what's going on, and how we can help them to implement. Louisiana has been working towards having the Children's Advocacy Centers become their care coordinators across the state of Louisiana as well. And yeah, our team has been kind of spotlighted in some of the national work that's going on because of the public health approach that we're taking. So some intentionality in that, but also setting the standard for a lot of the activities that will transpire in other states as well. Some have a variety of models, but I don't know of any other state right now that has this position from the office of the governor. It's very exciting. But to see the governor's spouses come around and say, how can we do this? It's been really, really good. So this session really is just an overview of the Lighthouse platform and the See It tool. The See It tool is the commercial sexual exploitation identification tool. This is a piece that I mentioned in the first session so that you could kind of get your mind wrapped around what are we going to be looking at, what does this look like, and how do we assess this. So we do this training every month. Our team does a virtual training, and we can do specialized, customized trainings for any of your agencies that might want to have opportunity to see about implementing this into your policies and procedures. And it is an information integration tool, which we'll talk about in many respects. It's one of those that you could do with or without the Lighthouse platform, and you can look at the research base and those kinds of things, but we're really trying to put this on the Lighthouse platform so that we get aggregated data about the screenings that are going on across the state, and I'll show you some of that in just a minute. So again, it is just the overview. This doesn't authorize you as a user of the Lighthouse platform or the See It tool. The commercial sexual exploitation identification tool was assembled through the research program of the West Coast Children's Clinic. It is available. If you go to their website, you can actually download the tool. You can download the research on it. You can see what they've done to make it a research-based tool and the final report of that. You can look it over, but they want everyone to get the same standardized training. It's kind of like an art and a science altogether, much like work in the psychology realm is. You have the DSM, and I don't know what they did before the DSM, but it's kind of an art and a science of understanding what's going on with an individual and the way that that presents, and then understanding how to diagnose that. Well, the tool is not an assessment tool. It's not a psychosocial assessment, but it does allow you to see some things in a rubric of assessment that kind of brings the puzzle pieces together, and I think that'll help you today to see things you might not have seen before. You notice it's commercial sexual exploitation identification tool, but we say it, see it. It's kind of a play on words because you'll be able to see, SEE, things that you hadn't seen before with the See It tool. So let's get started. You all are professionals, you know to take good care of yourself, but the information in this can be a little triggering for some folks, and I just want you to have permission, if you need to get up, take a breath, take care of yourself. So, because I covered all of this in the first part of the session, I just want to remind you that there's these 5 public-facing pieces, and recognize is the location at which the tool fits. This is where we begin to have that conversation about how do we see what we haven't seen, and how do we start to see it. So we talked a little bit about vulnerability and grooming in the first session. There's lots of options for understanding underneath the surface that there's things that are happening that make our children more vulnerable, and they're easily groomed and recruited in the online space particularly. And then the abuse and control that goes along with that for those that are being exploited or are being commercially sold in sexual exploitation. And then there's that trauma bonding piece. Just to refresh your memory, when we went over this at the first session, it's a reminder that all of these elements are present in the stories that we look at for these kids. So included in your materials is this case study. It's kind of a vignette that we've used before in teaching and training on the tool itself, and kind of helps us to frame what we're going to be looking for from this vignette. So I'm going to read it to you. Jade is a 16-year-old Afro-Latino female. When she was 3 years old, she was removed from her home due to substantiated allegations of sexual and physical abuse. From ages 3 to 11, Jade was placed with over 5 different foster families. When she was 11, she was AWOL, absent without leave, from placement for the first time, and had her first sexual experience, a sexual assault by an older male peer. Jade's case file shows that the sexual assault by a male peer at age 11 was part of her being forced into sexual exploitation. Since age 11, she has run away from multiple placement and relies on emergency room and other temporary medical settings for all of her medical needs. She reports she was recently treated for another STI and has a stomach ulcer. Jade struggles with finding and maintaining healthy peer relations, is on a behavior plan in school for her poor attendance record, and has a 30-year-old boyfriend. Remember, she's 16. She met him through peers while in a group home. She reports that her boyfriend doesn't like her to have friends and gets jealous when she talks to other people. She shares that she rarely sleeps well, always gets in trouble in her foster placements for losing her temper, and uses marijuana daily to help her stay calm and get through the day. Big, deep breaths, right? That's really a difficult vignette. But I want you to begin thinking about this vignette in light of the materials that are coming forward in the presentation. In light of what I'm going to show you, some of the things that you see in this vignette are going to be elevated by the key indicators and the substatements that are on the tool, and this will help you to frame it. When we do the training on it, we use a different vignette than this, but we do the training from the vignette and do this more intentionally with 8 key indicators so that you get how this process works and the art and science of it together. We talked about the pair of ACEs and understanding that adversity is a part of what we have to assess for, and understanding where these children are coming from as well. And then this is the third realm of pieces that I mentioned earlier. This is what our friends at DFPS and the ACES connection are using, because that storm that's looming, not just the one that's coming tonight that we know about, but this storm that's in the picture is kind of what has happened with the pandemic. There's this unknown force that just sweeps over everyone, and that has become more evident as a complex trauma indicator for children of vulnerability, and adversity is coming because of a lot of these different things. We talked about the roots and the fruits and that kind of stuff. This particular graphic from acesconnection.com is really well done and has a lot of those same issues as the pair of ACEs study. There's been a lot of increased vulnerability for our students in the online space since COVID. We have numerous research projects that have indicated that because of their online exposures and not being in school where they have access to a trusting adult or their peers, that their vulnerabilities have been greatly increased, and economic hardship also is a key piece to understanding that they could be more vulnerable to trafficking because of that. Again, the technology piece plays an important role. We're going to talk more about each of the indicators, and the cell phones are one of the substatements you'll see. So we talked a little bit about familial trafficking, and our laws in Texas state the Department of Family and Protective Services is responsible for investigations. They have special investigators for kiddos who are trafficked by their family members. That also includes if they're under the care, custody, and control of someone other than a biological. For instance, if they're in a school setting and they're being trafficked by someone in that school setting who's supposed to be in care, custody, and control of them for those periods of time, they also can be investigated by DFPS rather than regular law enforcement. But any other cases, those are law enforcement specific investigations. So our Department of Family and Protective Services would be working on familial trafficking, and that's the primary caregivers, those kinds of things. And again, I told you that familial trafficking is especially prevalent for kids who are 10 and under. The younger the child, the higher the likelihood that it is familial trafficking. And with the crisis that we have in opioid consumption and drug use, it becomes a viable option for parents to be able to exchange the sexual abuse of their child for the drugs that they need for their life. And then the romantic partner, we've in the past been called Romeo exploitation. The problem with using Romeo is that you assume that it's a man and a woman like Romeo and Juliet. And the reality is it could be a romantic partner no matter what the gender or their orientation is. And so we've started using romantic partner to describe that. Actually, it's that kind of relationship that is the jump point for them to get exploited when they don't understand that that's really not a true romantic relationship. And then violence-based is formerly known as guerrilla. Sometimes in public it's called guerrilla as in what you find in the zoo. And it's actually guerrilla as in guerrilla warfare because it's based off of the violence and the threats of violence that are so prevalent. It's a lot of actual force used on these kids to keep them compliant and in control. And then we have peer-to-peer recruitment. It's happening in our schools and in other organizational structures that children are involved in where they might have someone who recruits them. We find this in some of our residential treatment centers that may have kids who are trafficked in there, and they may or may not be a specific population that they are using those facilities for only trafficked kids. And you get a trafficked kid in there who is going to run, and then they take somebody with them, so it could be a peer-to-peer kind of recruitment as well. And then gang-based recruitment. Gangs are turning to the prostitution of children, forced prostitution, as their most lucrative means of income. And you can sell a drug or a firearm one time, which has been the historical money generators for gang activities. But what they have found is that they can sell a child over and over and over again. They make that child believe that this is their activities on behalf of the gang to have the income for the gang activities, and that this is just their job. So they don't see it as exploitation, and they certainly don't talk about it in those terms. But there's a lot of gang engagement when it comes to trafficking of kids. What we have seen even over the last 10 years is that there's sometimes turf wars for gang activity and who's going to control what area of the community. And we also see that it's so lucrative in some locations that gangs will actually collaborate or cooperate with one another in order to have the businesses in that particular geographic area. Internet enticement and exploitation. We've talked a bit about that in the last session. This is where the majority of kids are getting their first exposure to exploitation and exploitative behaviors. And it's easy for those who are looking for children who say, For example, a girl in Denton got online on her, I think it was Facebook account, and she said, "I hate my life, I hate my parents." And somebody who was a friend of a friend of a friend, you know, somebody she really didn't know, who was able to see her page, said, "I'll come get you. I'll be there in 45 minutes. And she picked her up from her home, and she took her to a hotel, and there awaited the trafficker, who immediately was sexually assaulting her and putting her out in prostitution. It happens that fast. It doesn't always happen in person immediately like that, but it does have a longer grooming period online intentionally to move a child into a space where they'll talk about sexual things in their life. And we see a lot of that in the way that law enforcement approaches this for their online stings as well. And then survival sex, I really hate that term. It's exchanging sexual abuse for something of value, something that they need to survive today. It could be food. It could be, you know, warmer clothes. As winter comes, they need different clothing if they're out on the street. We have runaway kids for many, many reasons. We have throwaway kids. People are no longer looking for them. They've been jettisoned from their families, and so there's a lot of kids who are living in these situations where they're just exchanging what they have for something of value. And then we have illicit sexually oriented businesses. You notice that's called SOBs on here. You may know that term SOBs is something else, but it actually stands for sexually oriented businesses in this context. We know that this is a huge problem across the state. The Children at Risk group has done some extensive studies on the proliferation of sexually oriented businesses, massage parlors, false fronts in nail salons where they actually have sexual exploitation going on in and around those facilities. So there's a lot been being done to address this in our state, and many of those are licensed facilities that are getting a second look from our licensure department about what's going on in those locations, as well as many of them are allowed in local communities based on the standard of that community. So it depends on what your local city ordinances, you know, county laws and that kind of stuff are. So if you would want to address sexually oriented businesses in your community, maybe it's something that you could do with your local government officials to make those unacceptable in your communities. And then a lot of people have seen the movie Taken, and so they think of trafficking and Taken as the gospel of how this happens, but the reality is kidnapping is very, very rare, except for a few pockets of communities where this has become standard for many of our tribal communities and things like that, where they have seen kidnappings happen. It's very, very rare that we would see a kidnapping as a part of that. So you probably have seen some lists of red flags in the area of what to look for. So it could be unexplained absences or chronic running away. It's this whole list, and you have them in your handout. But what we found was you can't remember all of these lists all the time to apply to a certain situation. For instance, Jade's story, would you want to go through and try to figure out if any of those were in Jade's story? Or would it be better if you had a really easy tool that would help you to figure that out, right? Because there's more than just that list. There's the whole list of the medical and psychological things that might present when it comes to this. If they have untreated or old injuries, how did you get that bruise? Where did you get that bruise? When did you get that bruise? What are these injuries that you've had, and what are those things that are exhibited in their physiological appearances and in their medical complications, for instance? You might not think about this, but neck injuries are quite common. Asphyxiation and suffocation and impeding of breath. All usually a neck injury could be involved, but there's also some damage to the brain based on a deprivation of oxygen. And I would venture to say that there are some cognitive capacities that are really affected by those kinds of activities that have gone on in their life during their period of prostitution. And The other pieces that come along with that are dental issues, unattended medical issues in the mouth, and those sexually transmitted disease, HPV in the throat, mouth, those kinds of things. And they start to present, and we don't know the genesis point of a lot of those things until we start asking the right questions and understanding how that child has come to have those things. And then in the mental health area, we know that kids are experiencing not only trauma, but complex trauma. It's persistent over their lifetime. It's frequent, and they're responding the best that they know how. They are maybe either stuck on or stuck off in their response, where they're hypervigilant or their affect is low and lethargic. And so we might have to begin learning a little bit more about how those present and what they might see. And they're living in such trauma that I don't think that their brains are able to process the trauma and package it in a way that's understandable. So telling the narrative and retelling the narrative, it might not come out the same way because they remember it differently based on the question or the way that they're telling it, and they sound like they're lying, where in reality is that their files are not. I know some of you are old enough to remember that you had to defrag your computers, right? Yeah. So we generally don't do defragmentation much on our computers anymore, but it's like all the files got mixed up somewhere, and the traumas that they're facing mix those files up in their brain, and it's hard for them to remember things in order. It's hard for them to remember them sequentially, but also cognitively. They're in pockets in their brain and in their memory because of the trauma that they can't seem to, it's fugitive information for them. They can't seem to locate it and tell it accurately. We talked about the trauma bonding, and we talked about looking at this webinar and the pieces of this that deal with isolation and the disruption of their personal relationships is a part of their not understanding how relationships are supposed to work. We know that their prefrontal cortex isn't fully developed until they're about 25, and so they're experimenting and doing things and engaged with people who are actually teaching them things that are wrong rather than that are right, and they don't understand that. And that trauma bonding can be pretty difficult for them to respond appropriately when someone tries to build a rapport, build a relationship. And that's a piece of this tool, is that it works best if you have a rapport with that child, if you're doing it as an interview style or in conjunction with questions that you ask the child. But it's not designed to do that way. It's actually designed to integrate information that you have from a variety of sources. So whatever assessment you're already doing is the best place for you to gather that information rather than asking the child more questions. So we talked about this trauma bonding, and I just would want to make sure that you understand that they're often being alienated from authorities and family members, and they're told not to tell you anything. That's a part of the isolation and trying to buffer the individual who's exploiting from what could be activities of investigation and those kind of things. So we talked a little bit more in the trust-based relational intervention. They deal a lot with attachment disorders and the need to change our thinking about this from what's wrong with you to what's happened to you. And that, I think, in and of itself will help us to get to the root of the problem. All right, so Screening for CSA Advocacy is an information integration tool built on the premise of universal screening. Where we have seen this implemented as a universal screening in our Children's Advocacy Center, those that screen every child that comes through their center, they're seeing results in keeping with the evidence-based research, about 10% of their kids. And as a part of that, we're trying to help folks to systematically think about those whole lists of indicators, but with more specificity to the 8 key indicators that we'll look at. This helps to keep our thinking aligned and allows us to not get distracted by 1,000 different lists of what could be, but really ask some pointed questions that help us to uncover what's there. We will be identifying victims more quickly and efficiently. We'll be able to see what's happening in their lives, and in those 8 key indicators, we can begin to address the challenges that that child's facing in any one of those key indicators and provide the wraparound care coordination services that we talked about earlier. So screening is the first step to identifying. If we don't screen, we cannot expect that we're actually going to know for sure what's happening in that child's life, and we're not going to know for sure unless they say. But the misnomer is most children who are exploited don't know they're exploited, and they are not going to make an outcry, especially if it's relationship-based exploitation. The tool was research-based with a group of organizations and over 2,000 kiddos in California, and they had kiddos who were 10 years old and up. That's why the screening is designed for as a research-based tool for 10 and up. We do know that some of those indicators are also present for kids younger than 10, but in keeping with the research base, we are recommending universal screening of children 10 and older. Exploitation happens early, and it happens for longer periods of time than we know. Children are often not recognized for more than 2 years that they're being exploited once they have had someone who understands exploitation to screen for it. So we knew that we wanted to be able to visualize this data of all the screenings that we have in Texas with more depth, and to be able to see what the trends are for any of the 8 key indicators and all of the substatements. And this is helping us to design programmatic elements on prevention, recognition, recovery, and supportive healing in those areas that have elevated as most problematic. That means we can work more effectively and efficiently when we have programs that meet those needs in advance of that happening in that child's life. So Lighthouse is a platform that's available on your cell phone, your tablet, your computer, and it's put together by a group called Allies Against Slavery out of Austin. They're developing a way for our grantees to also report their measures. We have care coordination reporting their measures there. And we're going to have Rice University doing some research projects around the measures that we've been collecting for about 3 years now to tell us more about the story. So this was as of September when I was working on this presentation. We have had over 50,000 screenings now. And the green is the no concern or no information. That means we do not know something about what was asked on the screener, or we have no concerns at this point. And then the yellow is the possible concern, which means we have a little bit of information, but we're not really that concerned about what we see right now, but it's something that we can watch and wait and see if there's some services that might be applicable for a kid with a possible concern. And then clear concern is what we call a presumed victim. If a kiddo scores a clear concern on the tool, it means action needs to be taken and that appropriate services should be provided for that child. And if they are in a situation where they need to be extracted, law enforcement would get involved for them to be able to come out from an exploitative situation that they may be found in. So clear concern is our action point. So from Jade's story that we read earlier, rethink about some of the things that I've just talked to you about, some of the challenges that she's faced, some of the adversity that she's faced, and some of the present realities for her that have surfaced. And you'll notice in here, it started with this connection to the Department of Family and Protective Services. She was bounced around quite a bit, and then she was sexually assaulted at 11 and forced into sexual exploitation. So there were some things that happened in advance of all of that. And then there were some outcomes here for her to cope with all that has happened to her. She started using drugs and marijuana, but she was also dealing with sexually transmitted diseases and those kinds of things as well. So we're going to look more specifically at what's on the tool and the substatements. So be thinking about Jade's vignette as we do that. So these are the 8 key areas: housing and caregiving, prior abuse and trauma, and some of our measures are over the lifetime of the child, and other measures are within the last 90 days on this tool. So we're looking at mainly the last 3 months, what's happened in the last 3 months in this child's life when you have contact with them or when they come into your facility. Then physical health and appearance, environment exposures, relationship and belongings, signs of current trauma, coercion, and exploitation. So those are the 8 pieces that the tool looks at. Those are kind of the pillars on which we will work, and it gives you a whole 360 view of this child in many ways. So how this tool is scored: you have no information, which means you literally have no information. No concern, which means there's something there, but you're not sure what you have, and it may be older than 90 days if it's a current indicator, and you just don't have enough information to really make a determination as to possible or clear concern. So then possible concern is where you're looking at the information you have. It may be older than 90 days, but you're really, you've got some good pieces there that you want to make sure that get noted. And the art and science of doing this tool is that you want to score low versus high because it's a weighted tool. And they weight based on what the criteria are that they developed, and that means you're going to get an outcome that you don't want to skew by false information. It's like the COVID test we took to get in here. You don't want a false positive, right? Same thing here. We don't want a false positive when in reality we have not enough information to take action on. And then the last one is clear concern, information that's observable or that you have from the information that's available to you, and you know that it's a clear concern on that specific statement. So, anybody with a telescope back there to be able to see any of these? You have them in your handouts. You have them in your handouts, so it's that's printed in the materials that they gave you when you came in the door. But I'm going to read a few of them to you so that you kind of get what this looks like. So housing and caregiving is the youth experiencing housing or caregiving instability for any reason. And then you can see it's got the 4 columns of no information, no concern, possible concern, and clear concern. And the first one is the youth runs away or frequently leaves their residence for extended periods of time, overnight, days, weekends. One of the things about Jade was she was running. She was running a lot, remember? So when we look at this one, and we know that about Jade from her story, we would score it a clear concern, or a 2. Okay? Then the second one is youth experiences unstable housing, including multiple foster group homes and placements. Was that a part of Jade's story? Yep. Clear concern. And so we could go through each of these, and when we do the training, this is how we do. We go through each of them. We have the vignette. We look and we make them substantiate their answers based on the vignette so that they understand you don't make stuff up. That's the difficulty of this tool. Well, we think, well, if this, then that, and of course she did this, and so that must mean she did that. Well, we don't want to go that way. We want to go based on the information that we have, and so the tool is designed so that you're asking of the information available to you. And remember, this is an information integration tool, which means if you have information in any of their records, records from school, records from historical treatment, you have access to information about this individual that you can use towards the tool and doing the integration of the information. It allows you to ask questions of the individuals who may have knowledge as well. So let's say the kid's in conservatorship, they're a DFPS kid, they have a CASA worker who comes to visit them, right? And the CASA worker would not have done a screening tool, but you have a question about this child, and you can ask the CASA worker, do you know anything about this kid's blah, blah, blah? And if you can get information that way, that's preferable. This isn't designed for you to sit down in front of the kid and do a checkoff. It's never designed to give it to the kid and let them answer it. It's always a way for you to take the information that you do have at your hands and at your disposal to make an assessment based on what you do know. So we don't need to make stuff up, and we don't have to surmise, well, if this, then that. So at the end, when you've scored these 7 items, down at the bottom there's a light gray bar, and it weights it. So what you do is you add the numeric value of each of those until you get the subtotal number of all of them, and then across the bottom it shows you if it's 0 to 3, it's no concern. If it's 4 or 5, it's possible concern. And then a subtotal of 6 to 14 means it's a clear concern. And that clear concern on this particular key indicator will be placed on a tally, and it will be a part of the overall score. Now, if you get a clear concern in housing and caregiving, there are maybe some actionable items if you don't get an overall clear concern on this child's score that you could help with if you have access to what caregiving and their situation at home is, to begin addressing those things. So this is the same indicator, but this is what it looks like in Lighthouse. Looks very similar, doesn't it? They took the tool, they designed their computer program to look just like the tool, and instead of you having to do any math, for all of us social workers out there who love to do math, no, this is a real helpful thing, because then it calculates all of it. It tallies the final score, and it does all of that behind the scenes. So the tool in Lighthouse is really quick and efficient. Once you learn this tool, you go through the training, you learn how to implement it, it should take you 5 to 7 minutes to answer the sub-statements and get a score for that kiddo. So this is what Lighthouse looks like, and there's a website that you can go to learn how Lighthouse functions, what it works, how it works, and what you can do to get licensure and stuff to be on that platform. And I'll tell you about that in just a little while. So prior abuse and trauma is the second one, and these are all lifetime indicators. One of the pieces that they did in the research was to look at where the preponderance of prior abuse and trauma were in these kids' lives. And they elevated 4 of those specific lifetime indicators for these children. The first one is youth has been sexually abused. Was Jade sexually abused? Yes, clear concern, because it was over her lifetime we're looking at, right? Youth has been physically abused. We know that about Jade. Clear concern. If the youth has been emotionally abused, now this one is a little tricky, because it's hard to know what emotional abuse looks like unless you're pretty intimate with the details of what went on in her life. So we would want to not make an assumption that with all the other things going on that there was or wasn't emotional abuse, right? We have some possible concerns based on all the information that's already in her vignette, but we're better to score it low than to score it high and get a false positive. But if you look, the last one is witness domestic violence. Domestic violence is a precursor to a lot of folks who are in the criminal justice system, just so you kind of keep those in perspective. And the slide that I showed you from the Florida research, domestic violence in the home was one of the key pieces of those kids that were trafficked in their residential facilities. So then the subtotal is 0 or 1 is no concern, 2 is a possible concern, and 3 to 8 is a clear concern. So heavily weighted again. If it gets even to 3, you've got a clear concern here. So starting to make sense? Yeah, so we've got clear concern on the first one and clear concern on the second one. And then this one has to do with physical health and appearance. And this one has 5, 6, 7, 8 statements. So it's a little more in-depth. And it allows you to look at more things about this child's life concerning their physical health and appearance. Now, there may be some things that you would want to score here that are also going to be questioned in a later key indicator, but we want to stay pretty specific to what those questions are that are here and not overlap, because the scores will automatically converge at the end. So the top one is youth presents a significant change in appearance, stress, hygiene, or weight. Do we know that about Jade? Because all of these are in the last 90 days. I don't think so. And then let's see, the youth is sleep deprived or sleep is inconsistent. Yes, they said she didn't sleep well, she had trouble, difficulty. And we look at sleep here, and we'll also look at sleep under coercion, because if someone's keeping her from sleeping, that's a whole different piece of it, right? We don't have that element. But this one, we do know that she's having inconsistent or trouble sleeping. And then the last one is youth experiences significant change or escalation in their substance use. Substance use is often a compliance tool, and it's a coping tool for them. And so what we look for is if there's a significant change or escalation. So she says in the vignette that she's smoking marijuana daily, right? Yeah, it's coping for her. So then we get to the bottom one, and we get whatever the numerical total is, and 4 to 16 is a clear concern, and that will be what we take to the tally score. Of course, if you're doing it in a lighthouse, it's all automatic. Environment and exposures includes the youth engages in sexual activities that cause harm or place them at risk of victimization. Sometimes very difficult to know these answers, but we don't make stuff up. We answer what we do know. And then let's see, the youth is bullied or targeted about exploitation. The vignette that we use in the training says that she doesn't like going to school anymore because the kids treat her badly. And it doesn't say clearly that they're bullying her about being exploited. So it's hard to know what that's about. But we could score it as a 1, a possible concern, right? And then the last one on here is gang affiliation. And remember, I told you before, gang affiliation is a high priority because gangs are turning to the prostitution of youth as a means for income. So then we would, again, take the score. This one is really heavily weighted, and if you get a 2 to 14, it's a clear concern. Then relationships and relationships and personal belongings. So one of the big things about Jade's vignette that disturbs a lot of people is she's 16 and she had a 30-year-old boyfriend. That would be covered in these substatements. Youth has unhealthy, inappropriate, or romantic relationships, including but not limited to with someone older, an adult. So it's usually the rule of 3 years. 3 years older, 3 years younger. But when you're talking 14, 15, 16 years difference, that's a significant indicator that someone is being exploited for that relationship. Then it goes on to ask several other things. I want to include this one, which is E, youth has several cell phones or their cell phone number changes frequently. A lot of what's going on for these kids is in that space. Their cell phones, their accessibility by cell phone to the person who's exploiting them, their contacts and their dates that they're making almost always are on that cell phone. If they have more than one phone, that's an indicator that you should be watching for. But if they have what seems like an unhealthy attachment to their phone, I don't know many teenagers who don't. Just saying. I got a 14-year-old grandson, and he's like always on it. And so it's hard to know whether it's the normal culture of these kids or if they're just super hyper vigilant about their phone. That's when I would be concerned. So then the subtotal 3 to 12, again, weighted pretty heavily. And then the next one is signs of current trauma. This would be psychological trauma, that includes being on edge, preoccupied with safety, or hypervigilant. Also, difficulty detecting or responding to danger cues, engages in self-destructive, aggressive, or risk-taking behaviors, and a high level of distress about being accessible by phone. That's where the access to the phone issue is being looked at in this statement. So we're already up to number 6, and yet one of the things that I think is probably missing from understanding a level of distress is a kid who comes in with their response stuck off, like they're lethargic, or they're non-responsive, or they're that look of deadness, that they're just not reactive to you, is that they also would be in distress, and it wouldn't be noted as hypervigilant. It's these hypervigilant kids that usually get the most attention, right? And the other ones are just like, okay, we can deal with this, and maybe it's just ... Well, I would say be thinking about what are the presentations of that child, what are their psychological distresses that they're bringing forward that you can actually see, and score the statements as given and as appropriate, but think about what else could be going on here, okay? Then the next one is coercion. We talked about those elements of coercion that legislature included in trafficking now. If someone is forced to take drugs or forced to engage in alcohol and those kinds of things, that level of coercion is now a part of trafficking definition as well. This one, the youth has an abusive or controlling intimate partner. Now remember, we asked about the older boyfriend before, but this one is about abusive and controlling partner. So it's not just the age or a romantic relationship, but someone who's abusive and controlling. Then another one is someone's not allowing the youth to sleep regularly or in a safe place, go to school, eat, or meet other basic needs. This is one I mentioned earlier. It's not just about inconsistent sleep or not sleeping well, but that someone is keeping them from. It's a part of that trauma bonding, remember, that isolation piece, to remove them from normal functioning and daily life and the opinions of others. And this is where we're going to be looking at the coercion side of it. And then the last one, youth gives vague or misleading information about their age, whereabouts, residence, or relationships. Is this typical teenage behavior? Or are we asking questions that would help them to give us more detail? Or are we looking in the right places for the information that we have available to us? I suspect there's going to be some of this that you just aren't going to have any information on this kiddo at all. So you answer it appropriately. No information, no information, no information. And you can screen and you can rescreen these kids. In fact, West Coast Children's Clinic says that if you're in relationship with this kiddo and you're going to be seeing them for services, or that they continue to be in your services for more than 30 days, you probably should rescreen and see if more information became available, because this is a snapshot of what you know at a given point in time. And you may learn new things and be able to answer it differently based on a relationship building process that you've accomplished with that child. So then this one is 2 to 12, heavily weighted, so that if you even reach 2, you've gone to the clear concern. And then exploitation, this is the last of the 8 key indicators. The youth engages and exchanges sex for money or material goods, including food or shelter. And there's just 4 questions here. The youth is exchanging sex for money or material goods, including food and shelter, for themselves or someone else, like their child, a family member, or a peer partner. And then youth is watched, filmed, or photographed in sexually explicit manner. The online exploitation, those kind of pieces would be in this category if they're watched or filmed in that manner. And then youth has a history of sexual exploitation. You remember when it says youth has a history or it's a lifetime indicator, that means over the lifetime of the child, not just in the last 90 days. So what do we know from Jade's vignette? She was sexually assaulted at age 11 and forced into sexual exploitation is what the narrative says. So we know this about her, so we would score that clear concern, right. And then the last one is youth is forced to give the money that they earn to another person. That's a third-party trafficker controlling them. And then this one is weighted pretty heavily too. If you get to a 2, you've already got a clear concern on this particular indicator. 2 to 8 is clear concern. But when we score this and we put it on the tally, this is superiorly weighted in the whole of it, where if you get a 1, it equals 4 on the score, and if you get a 2, it equals 9. So you can see how that they weight that really, really heavily. And this is what it looks like for the platform, the Lighthouse platform. It tells you all of the 8 key indicators, what your score was, your outcome score down the center column, and then what percentage of information you did not have in that particular indicator. And it will total all of those, and it will give you what the outcome is for the overall, and a clear concern was what the outcome was in the example. So it gives you the green, the red, and the yellow, kind of like the red light situation. You know, if it's green, you go. If it's yellow, you slow down and stop and look at this. And if it's red, that's when you need to take action. Determine an action and follow through with that. So that rating indicator is about the level of indicators that show a possibility of sexual exploitation. They're either already being exploited or they're at high risk of being exploited. And we've worked intentionally with the FPS to learn the language that will help to articulate this. And if you get a clear concern, this is what we call a presumed victim. That means you're going to take the actions that we talked about earlier, and I'm just going to reiterate those. You can report this to statewide intake, just like you would any other victimization of a child. You can report it to local law enforcement if you think it's imminent. DFPS, when they do statewide intake, you can give them the clear concern, you can tell them what the score was, you can tell them, you know, anything you know about this child. You can tell them if you know where the victimization occurred, that kind of thing. And they will, if it's not a family member or those caregivers that we talked about as familial trafficking investigation, they will route that to 2 places: the local Children's Advocacy Center and law enforcement that would be responsible for it. So then those cases that come through that way would be reviewed, and action would be taken by the Children's Advocacy Center and or the local law enforcement agency with whom they would be responsible for working. So we want you to make sure that you're making those reports. And again, if it's non-emergency, you can call the National Human Trafficking Hotline. You can do the iWatch pieces of it. You can make some action to do something on behalf of that child, a part of your protocols. So when we look at agencies wanting to get trained for the See It tool, what we're seeing is a lot of people are getting trained and they need assistance to implement it in their policies and procedures and the way that they do their work. Many organizations, many situations are already doing the CANs. They're doing psychosocial assessments. They're doing all of these other pieces of assessment for these kids. And all that information is a part of the relevant information for doing the tool without having to add many more layers of interviews and all of those other pieces. You do it based on what your current policies and procedures are, and you integrate the use of the tool by saying, when we do this, we will also do the See It tool. See It tool is going to take you 5 to 7 minutes, depending on how much information you have available, and we encourage you to pre-plan that exercise of inputting the data into Lighthouse, because you have to do it all at once or you're going to have to rescreen. So you come with all of your documentation, you know what you need to know, you answer through the questions on the Lighthouse platform, and that allows you to come up with a clear concern or possible concern or no concern score. You can actually print that PDF and attach it to files and do whatever you need to document that. This is a secure web platform. They are HIPAA and FERPA compliant. So all of your data is your data and your data only, and the only thing that gets looked at by us is aggregate data in the big picture. So that way we're not seeing any individual data from your organization. We're not seeing individual screenings. So what would it look like for your organization to implement? What would it look like for you to have what you need in order to do this? And it takes a bottom up and a top down approach. Let me say that again. It takes a bottom up and a top down approach for the integration of this to become relevant to you. We would like for universal screening of 10 and up, and have it implemented in such a way that it's done by all the parties that are relevant to this child's case. If you are working with someone else who's already done the screening tool, they can provide you with the information about that screening. Say you had a CSA advocate who's engaged with this kid, and they've already done the screening because it's required for them to do it, and that child comes to your facility, you can ask that CSA advocate agency, do you have a CIT score already on this kid, and what would that be? And you can use that information to help you as you relook over time as to what you know about this child and how you can assist them. We would want you to have a plan. There's a licensure agreement, just like when you sign on to an app, you have to agree to all their verbiage about use of that app. That same thing's true about using the Lighthouse platform, and so there has to be someone who signs on to agree to the licensure so that your agency can access that information. And that becomes your data, but it is also available to bring into the research space and the aggregate data for us to be able to utilize it. So what would we want to have in our policies and procedures? An action plan. If you get a kiddo who's identified as a clear concern, you'd want to have a step-by-step process. It's gonna mirror exactly what you would normally do for a child who presents as a victim of any other crime. You're gonna follow that same process, but you just want to make sure that everyone knows if you do see it and you get a clear concern, it should trigger these actions to be taken. So we talked previously about care coordination. These care coordination teams are up and running. I believe that we'll start working on care coordination for this area of Texas. And we're already working in all these other places, and we're trying to fan out from the urban centers and make sure we have resources available for the more rural areas of Texas, which covers a big chunk of West Texas from here all the way west. And those care coordinators are the ones who become the air traffic controllers, and they will be the ones receiving the reports from statewide intake. So if you call, that should get routed through the Children's Advocacy Center. So access to Lighthouse, as I mentioned, takes several steps, but it also takes somebody with a signature authority in your organization. This is their website. You could go on and look around, plunk around, and take their webinars and do what you want to do with that. You can even sign up for user training. We can do your user training. But in order for you to implement this in your organization, you're going to have a licensure agreement in place in order for your organization to get on the platform. And we would really like for you to have a plan for implementing. The accessibility of the information that you put into Lighthouse is really awesome. It's visualized data, which makes it easily understood, because it's not a spreadsheet with 4,000 rows and all these columns, and that's kind of not consumer friendly. So it takes all of the information that you put in on the CIT, and it puts it in a display that helps you to understand where you're seeing from the substatements the highest level of indicators that these kids might have that are in your care. It also allows you to decide what demographic information you're going to be in there. The only thing prescribed is at least an alpha character or a numeric for the last name, and then it gives you an opportunity to put in to the system a a number that would be relevant to your organization to mask to us a lot of the information about that individual. If you feel like you don't want to put anything more than that, you can stop there. What we're finding, though, is that it helps us to know race, sex. They have options for sexual orientation if that's something that you feel like is appropriate for agency. They also have lots of other pieces of information and demographics that you can use or you can completely opt out of. It's somewhat customizable. We've done that for Fort Worth ISD. They actually are one of 8 cities in the nation who've received a specialized grant to address human trafficking in their school district, and we've actually already trained over 400 other counselors in the school district to do the SEEIT and to provide that information. So they've already decided what information they will put into Lighthouse, and then they'll be starting to see where they're finding the most challenges for their kids in their school district, which is pretty awesome. So when I started looking at the graphics that they gave me, I asked for some changes on the way that it appeared on the graphics so that we could see them in alphabetical order, or we could look at highest to lowest. And so I put this in a graphic that elevates the ID of the ethnicity that's represented. So African American screenings are, this is 9750. We've had more since this time, but for this purpose, there's almost 10,000, and about 1,000 of them are clear concern. It's in keeping with the research base on the tool that it'll be about 10% of our high-risk kids. So the African American community is in keeping with that. So when we look at the screenings for the Hispanic or Latino, look, we're looking at over 20,000, but we have 1,855 that are clear concern. Now, there may be some explanations for this. The reason we don't just make this publicly accessible is because there's more to the story than just the numbers. And that's where the way that they do the data is really important, to dig down just a little bit and to see more of what is there. For instance, of these 40,000 plus screenings, the majority of them have been done by the Texas Juvenile Justice Division. Well, the majority of those that are in the Texas Juvenile Justice Division are boys. And the number of clear concerns that we see for boys is about 5%, between 4 and 5%. And they're doing the training in-house on the SEEIT tool. They're putting that information into their platform called Noble, and that information is being transferred into the Lighthouse platform. And so we would think that these numbers may be not quite right, but what we're seeing is a high level of TJJD with a low level of identification, because it's not as readily accessible to us to know if a boy's been victimized. And we're working with West Coast Children's Clinic because this is our hidden population. Boys who are sexually abused have a high likelihood of exchanging sex for something of value to them in the future, and often don't work in the pimp culture and hide as runaways and throwaways and street boys. And unfortunately, the screening is very girl-centric. So we've talked with West Coast about that. We've done some listening sessions about that. And we have some specialized training that we're doing with the Texas Network of Youth Services around the issues for boys who are victims of sex trafficking. There is a documentary out called Boys, I think it's just named Boys, documentary that talks about how much more prevalent it is, but we don't have the research base to substantiate that. There's a few research projects that were done, some in New York City, but there was some skewed results because it was a paid for. It was almost exploitive, the way that they had the boys come to be a part of the study. And so we have to really look carefully at what we're getting in the data and analyze it, not just go, oh, this is that. And so we're being very careful and judicious because we're building this from the ground up and really want to know that it is accurate and reflects what we have going on here. So this is number of screenings, not necessarily number of children, too, by the way. Okay? So what would be your training and technical assistance on this? Our team provides that for the state of Texas. We have worked really closely with West Coast Children's Clinic and the Lighthouse platform to make sure we have tools available for you for not only learning the tool, but implementation of the tool. We have a whole presentation on what the tool can do for your organization and implementation of that. We're glad to provide that for you free of charge. When Lighthouse began, they didn't ever expect that they would have an organization that would have more than 100 users, but they had planned for it in advance. So for any organization that has 100 users or less, it's free of charge. If you have more than 100 users, then you would have a fee structure that Lighthouse would work through with you. But you also would want to make sure that you have the right people screening. You don't need everybody screening. You need the right person screening. So we worked with Fort Worth ISD, like I said, and we decided that with them, they would work through their counseling department and not expect all the teachers to get trained on how to use the tool. And yet we have close to 500 users already for them. And so they've had to be pretty prescriptive about how they're going to function, how that team's going to function, and they have a whole protocol that they developed on that. It's something that your organizations could do as well to decide who's the best person on our staff to be able to work with this and to make it happen. And we can continue to be available to you to provide technical training. If there's a question on the tool, we can connect you with West Coast Children's Clinic and their folks who developed the tool and help you to understand the tool itself and why it's these questions, why it's this and how it's weighted and all of those kind of things. So when it comes to who to contact, I'm understanding that you guys are kind of like all over the state. Is that right? We have people all over the state. I would say you can contact our office at CSTT, which is Child Sex Trafficking Team at gov.texas.gov, and that administrative assistant will route you to whoever is your normal CSA advocate. I'm sorry, your formal regional administrator. Oh, must be talking too much. And we can help you even if you wanted to provide an in-person training at your location, no matter where you are. We could work with you to either provide that in the virtual space or in person. We cover all 254 counties, and we're always looking for how we can partner with local groups on the ground who want to implement the use of the See It tool. So when you look at this and you think about Jade's vignette, what questions come to your mind about this child's life? Who does she live with? Where is she now? Yeah. Who is she living with? And we already know multiple foster care placements, and that's quite typical, especially if they're in the system that young. What other questions come to your mind about Jade? Is she going to graduate? On average, these kiddos who get exploited in middle school are more than 2 years behind of their peers, especially if they haven't been in school. We do have children who are exploited and still stay in school and are exploited on weekends and that kind of stuff. So they may be right under our noses, and we don't even know it. There's a group called A21 that has some awesome videos for education that they've done. If you go to a21.org, you can see they have some training videos that talk about that kid that's right under our nose that has some significant changes. Remember, one of the questions is about significant physical appearance changes, change of dress, how they interact with you, that kind of thing. And that video is designed for educators, but I think it's appropriate for anybody who has an organizational structure where they're seeing kids on a regular basis, and they may still be in public spheres, that they would have a change that would indicate that there's something different that's happened to them. Yeah. What other questions come to your mind? Does she have a support system? Yeah. When we talked about in the earlier session about supportive healing, and it takes a village to come around a kiddo that has significant challenges, what would that look like for Jade? Because we know she was removed from home early. She's been in the foster care system and moved around quite a bit. We don't know in her narrative of consistency in school, what would that look like? Did she have somebody who would support her there? We don't know if she had maybe a CASA volunteer or somebody in her life, a court-appointed special advocate. We really don't know from the narrative, but that gives us a lot of fuel, doesn't it, to think, how could we support this kid and get the right systems around her? We are working with communities and schools to see about what they might be able to do, because they work with the kids who are primarily McKinney-Vento children. I don't know if you're familiar with McKinney-Vento. It's the No Child Left Behind that was started many, many years ago, and the school districts administrate a lot of resources and programmatic elements that are specifically designed for children who are in DFPS, conservatorship, or who are homeless. And the homeless definition is very broad. They could be couch surfing, or they could be living in a mobile home park, or they could be living in a camper somewhere, So there's lots of different definition pieces that would be a part of that. Tell me what your questions are about the tool itself. Do some of those 8 key indicators surprise you? Yes, sir. Wow, that sounds like a really awesome research project. He's wondering what this might provide for psychiatric patients who come that may have been exploited, who you could do a retrospective study on. This tool is actually validated up to 24. So I think even doing the tool for our 18 and up is a significant place where you could do some learning. And any of those key indicators, substatements that are over the lifetime, would be a possible place of dialogue. And if you're doing therapy and things like that, it might be that you do the tool and you go, maybe I should ask about X, Y, and Z. Maybe I should help them explore what did exploitation look like in their life. Maybe I can help them to understand. Remember, most of them aren't going to know that they were being exploited, and they're certainly not going to outcry about it. So I think it could help you to make some exploratory type of options available to you, and what you do with whatever your cognitive therapy modality might be, to look at what has happened and how they can explore that as a mechanism for change or for recovery. There are other tools that are available that we could certainly help you to know those tools as well. They're pretty specific to street level exploitation, and they also include labor trafficking. You know, we're the child sex trafficking team, so we focus on sexual exploitation, but labor trafficking is a true and present reality as well, and it has physical and psychological implications. And there are children who have learning disabilities and mental health issues that are exploited because of those. And so we don't want to dismiss that somebody could have been exploited in a labor situation as well, and have a lot of psychological traumas because of it. I think it's all worth exploring, but at this point, use the tool and see what it shows you. I have an academic collaborative that I started here. For those of you who are researchers, I have a pretty good-sized group of academicians in the North Texas area. We also started a researchers group in West Texas. We have folks from Texas Tech, and I don't know how you feel about Texas Tech, but we can lay those things aside, right? I'm a Gator. I'm just going to be proud here for a minute, but we can lay those things aside because I have researchers from Texas Tech and San Angelo and a lot of other universities who don't always get to compete with the largest of our state universities to get grants and things like that, that have been working on this. They're doing some research on what students know about trafficking. This is really exciting to me because I have a, he's in the kinesiology, is that right? Kinesiology, sports exercise sciences, and he's teaching about trafficking to some of his students. And there's a professor at San Angelo that actually did a research project with a graduate student to find out what students know and what they don't know. And I don't think that they realize that they're also still vulnerable to exploitation based on things going on in their life as well. And that their knowledge base is kind of low. So they're doing some education of their students. They're really trying to raise the bar on what that looks like for them to not be exploited. And I had an opportunity to speak in Denton not too long ago, and there's a fellow that leads the Denton Coalition. It's called C7, and he's also a private investigator, and so he's following cases all the time, especially of children who are missing and runaway. And he did a little research project for the presentation that we did, and within 10 miles of the University of North Texas in Denton, he went and looked at profiles available online for what's called sugar daddy. Do you guys know that term, sugar daddy? It's where a student is looking for someone who will pay for their education in exchange for sexual services. He found in 10 miles there were over 1,700 profiles, and that was almost 5 years ago. So our students have been so saturated in this digital space and seeing sex acts as a commodity of exchange in that space that it's become a commodity that they see as available to them to get their education paid for. That's one school within 10 miles of it. And there's some community colleges and stuff up there. One of the groups called World Without Exploitation actually did some more research on the college campuses and found this to be quite popular. And Tulane University in Louisiana was one of those that they highlighted as a significant amount of college students who were using the platforms to meet and engage in sex activities to get their schooling paid for. So what I'm trying to explain is that there is a saturation in our social fabric of the exchange of sex for something of value, and our kids are learning that at a younger and younger age. And I think we have to be cognizant of the damage that it causes, not just physically, but psychologically and emotionally. And I dare say that the fabric is frayed in many places. I'm really concerned for this generation of digital natives. And I think we have to be savvy about what we're asking, how we're asking, and get to the heart of that matter pretty quickly if we have someone who presents as having had some history of sexual abuse. What other questions do you have? Yes, ma'am. Yeah, I think there's 3 actually that made the news. So those were publicly in the news, the cases in Wichita Falls. There was an arrest. I'm pretty sure Vicki Payne, is that a Patterson? Patterson. There's a guy named Patterson who was arrested for buying sex with children from a familial person who he was in contact with. And that was about a 1.5-year investigation, I believe, that the Department of Public Safety and local law enforcement were able to investigate that. I'm not sure of the details of several, the other 3, but I watch Google's alerts on trafficking cases all the time. Vicki Payne is here from Wichita Falls. She could certainly answer some of those other questions because she's trying to work on getting a coalition together in Wichita Falls. She has an organization called Southern Grit Advocacy. And if you want to hang around and meet Vicki, she's here somewhere and can help you. Is that you up there, Vicki? Okay. You bet. We have coalitions all across the state in a variety of locations. So if you're somewhere else and you want to know who's doing what about this, Dallas has one that's very active. They actually do a lot of engagement with survivors and do scholarships for them to go to school. We have the one in Denton I mentioned, C7, that they are very active. They do a lot of education in the community. We also have C7 Texoma, which is in Grayson County. And then there's some other activities in other parts of the state with coalitions that have been operationalized for a long, long time. In Tarrant County, we have what's called the Five Stones Task Force. Task Force is usually reserved for law enforcement specific operations to share information. But the police department was very proactive in trying to get together this, what they call task force, but it really functions as a coalition because it's a lot of the community members and non-governmental organizations that work together. Law enforcement comes and tells them, we're working on X number of cases, we've had an arrest, we've had, this or that. And so they're reporting out kind of the activities, but they're not sharing detailed information on those cases. But the coalition members are very active in doing community engagement and education and that kind of stuff. So if you need help with finding who those people are in your neighborhood, glad to help you with that. Yes, sir. I love a curious learner. Thank you. What do we know about the children of people who've been victims? The rate of prosecution is very low. These cases are very difficult, and they've been being prosecuted based on witness testimony, which is very difficult to not only obtain, but to really allow the survivor to heal. And a lot of times they don't want to put themselves in that position. So remember, I talked about collective liberty earlier, trying to train so that we don't have to have the victim on the stand. I think that's important, and that's a shift for law enforcement and prosecutors and judges to think differently about how they prosecute these cases. We've got to come loaded for bear with all kind of information about the perpetration and that that person was in fact trafficking this individual, and irrespective of whether she testifies or not, she or he, okay? So we're working towards that. There is a database called humantraffickingdata.org, and Dr. Vanessa Boucher put that together as a project for the Department of Justice. It analyzed typologies of traffickers, and it has federal cases that look at trafficking across the United States, but it's only federal cases. We're working towards a database in Texas for our cases, and the Office of the Attorney General's Human Trafficking Unit, Kara Pierce, who used to be the U.S. Attorney in Dallas, is now head of that team, and they're working towards having a way to look at the cases specific to Texas, but that's not quite ready for public consumption yet. These are challenging. They often take plea deals. So, for your first question, the children of those that have been trafficked. This is from knowledge using that database and other news sources and things like that, not an empirical study, so that it's clear I'm not articulating anything that's other than anecdotal from my knowledge. So traffickers are pretty savvy about this. They have a group usually of merchandise, a stable they call it. And I can tell you, horses in Texas get better treatment than the girls and boys in these stables. And it has become quite normalized for them to impregnate those girls as a trauma bond that's even deeper than the trauma bonds we talked about earlier, because now he's their baby's daddy. It's also a compliance tool. You get to see this kid when you go and make me $1,000 a day. $1,000 a day. No matter how many you've got, how many, appointments you have, you got to come back with $1,000 if you want to see this kid. There's one case in the database that kind of really broke my heart. It was a girl who was arrested for being what's called the bottom, and that means that she's administrating the stable, she's taking care of all the details, right? Well, she had a couple kids through this process, and she was being exploited by this fellow who was legally married to another gal that he had previously exploited. She became the stable mom and would do all the child care. He would not let the mother see the children unless she complied with his demands, and she had to work extra in order to see her kids. But she was prosecuted for the crimes that she was committing while she was being exploited. This is one of the things that we really want to see avoided, if at all possible. And that I talked about the clemency and the specialized responses that some of our victims have, because what we know is that many of them do have children while they're in trafficking, and that is sometimes really hard for them to be a good witness or participate in that system, but it's also hard for them to keep their children, especially if there's any drugs or alcohol and all of that kind of stuff, as a part of that, or arrest history, all of those things. But it's a really good compliance tool for a trafficker to use against his girls, and it makes it really doubly difficult. What I also see, though, is for youth who are coming out of trafficking, who are pregnant, or who have just had their baby, it can become that turning point. She's like, I got to get away from this. I want my baby. I want to do better, and I want to be better, and I need options. So a lot of our CSA advocate groups, they're hosting baby showers because the girls that are coming out are expecting, and they're putting around them, somebody asked about a supportive community. The CSA advocates become that supportive community and connect them to the resources in town where they're at to help them with, all of the basics that they need in order to take care of that baby. We actually have one residential facility here in Texas, SJRC, that's down in, I think it's Bulverde, that specializes in trafficked girls who are expecting and work with them when they have their children. We know that this is a big part of it, and we want those children to succeed and not have a second generation who's engaged. It isn't unusual that you have multi-generational, just like with criminal justice issues, we see that can become multi-generational. Thank you for the great questions. Anything else before I wrap up?
Right here. Yeah, so, sorry, apologies. I just wanted to say thank you for the grace that you displayed earlier today when you were talking and there were the technical issues. I thought you handled that amazingly well. Your poise was just amazing. And I appreciate leadership here, bringing you in to talk with us, because over the last few years there's been an emphasis on understanding this issue. And clearly they're trying to give us the resources that we need to do the job. So anybody that knows me knows that I said that to say this. You have been talking about the normative experience of you referred to Tulane University and girls prostituting themselves or using sugar daddies. We're seeing that in treatment, and I speak only for AFP here locally, but we're seeing that in treatment with very young girls who are prostituting themselves. They see it as a way out of their family home. They see it as an escape from abuses that they can't control, so at least that they have a form of control. When they become justice involved, we're able to use that mandate for treatment in a way that gets them opportunities for services that they didn't see. So anecdotally, one of the things that we see is that it is only until they become justice involved that the system really applies resources, and intense resources, and that the outpatient resources are not necessarily sufficient. I would not say that our resources are sufficient, and we're seeing two different responses from traumatized, particularly traumatized girls, but we've served some boys that we believe were trafficked. We see the narcissistic grandiosity and the narcissistic vulnerability, and recently there's been research to suggest that the vulnerability is really the true expression, that it just expresses itself in trauma responses that are violent. So my point there is that it's very easy for our staff to have empathy for young women, young girls that are that they're fight, flight, freeze. They're gonna freeze, or they're going to flee. They're very avoidant. They will minimize. It's very easy to have empathy for them because they appear to have a trauma response that's understandable. Whereas the young women that we have, the girls that have a violent response, the moment that you get close, they're acting out, it's all control. Function of behavior is very protective, and these are persons who have engaged in significant abuse of their peers, abuse of us as staff. We see them as people that need help, but reaching them, especially when they don't see themselves as victims, and it takes a great deal of resources to apply to them, those are things that we struggle with now. And are you, I appreciate any comments that you had to make, but I just wanted to suggest that if there's anything away from the research standpoint, more towards the applied work that we do, we would appreciate hearing about those resources as well. And again, I thank you for your time and your excellent presentation.
You bet. One of the things that you don't know about me is that I spent 12 years as a 911 operator, police and fire dispatcher, and I was trained as a police officer. So all of those things earlier today, my response was, nobody's going to die here today, I hope. But thank you for recognizing that I didn't get rattled too much by all of that. It's interesting, when the lights started going, I thought that we were going to have a mini explosion. Just saying. Oh, goodness. And I would say that the practice pieces and the application pieces have to come from within the discipline, so that you get the best possible knowledge base for you to apply. So the Heal Trafficking group that I mentioned early on has that specific mental health response piece that they take the synthesis of literature to the next level, and they're doing practical application as to what that looks like for modalities in the various kind of settings. So I would say that a deep dive for you would be to look at healtrafficking.org. We've also been working with our friends at Baylor Medical Center, and Dr. Elizabeth Newland is their chief. I don't know if it's psychologist or psychiatrist. I know there's a difference, and I'm not sure which her title is, but she's at Menninger. And I think that she could be really helpful because she's worked with us on this in the Houston area. And we rely on the experts in the field to tell us so that we can make our changes and give options for education that are specific for what your specific discipline is. So we wouldn't train law enforcement and mental health professionals the same, but we would want to give you options to take that path to where you can get not only information but application. It's always that distance between information and application that's our greatest challenge, right? So glad to broker introductions to any of the folks that I mentioned today, Dr. Greenbaum at Heal Trafficking, Dr. Newland at Menninger. They've become really great partners. And then I would say Tarrant County MHMR has 2 grants. And one of those has a federal grant about training their staff to engage in this space and look at how they're responding to trafficking victims specifically. And then they're doing another project that will provide that service in the local community. So there's the training and the application of that training to the services that they provide. It's Tracy Kohler at Tarrant County MHMR that may be able to help you to know what it is that they're doing and see about another option for you as well. We want to be all things to all people, but we know that our wheelhouse is gathering the right partners. So when it comes to how do we implement this in the local community, we want to see who's in the neighborhood, what can they do, how does this function, because it has to live on that the local community takes ownership of it. And that same thing is true for organizations. Who in your organization is that person of passion who would want to really take this challenge on to look for ways to respond practically in these situations? Now, as far as the kids getting younger and younger and exchanging, this is a protective factor issue. And I think at every point, no matter who has touches on that kid's life, we're going to have to educate them about how to put in place protective factors. We don't know what we don't know about what they're accessing on the internet until it's a little late. And I was having this conversation with some of the counselors at the school in Melissa yesterday, and they said, we have a huge problem with kids who are accessing porn. They're accessing porn really early, and they're getting addicted to porn, and they're acting out with each other, they're acting out at school, and it's affecting them, and we don't know what to do about it. So we made several recommendations about that, but I think some of this is a narrative that goes beyond just that they're exchanging sex for something of value. It's because that's a learned behavior that they're seeing in other places and spaces in their life. It's going to take all of us to really address it in a way that they can understand and help parents to put in place protective factors, and grandparents, for all of you who are in my age bracket, grandparents to help their kids to know what's appropriate and what's inappropriate. The internet has forever changed our lives, and the accessibility of children online is really creating a new paradigm for us to understand how we can help best. I hope that kind of helps give some direction to what you're asking about. I know praxis is really where we have to go, the practice of the information, and we're going to have to rely on the experts in the field to be able to do that. What other questions do you have? There's one down here.
ages up to 24.
Yes.
And as someone who just graduated college, I did see the sex trafficking a lot on the campus. Do you have something for the old 25 and up? Is there something like that?
Yes, there is the Urban Institute did a research project on what screening tools are available, and even if you just Google adult screening tool for human trafficking, you will get that Urban Institute report, and there are like 4 that they looked at, and most of them actually were designed for adults. And so that would be a real good place to find those specifically. What we liked about the See It tool was it was evidence-based. It was specific for youth, those that are under 24, and it was something that we could implement with integrity to know that it had been researched. Some of the other tools have some pieces that have been researched, but they weren't specific to the youth population. Yeah, if you don't find it, let me know, and I will excavate it for you. Anything else? If you would be interested in figuring out how to implement the use of the See It tool in your specific area or your organization, don't hesitate to reach out to us. We'll be glad to help you over the next several months to get the training and to get the licensure agreement and to see how that can be implemented in your policies and procedures. This overview may help you to really understand those 8 key areas. We don't always think of some of those when we're doing that list of flags, but when we start to put it together and screen it through that rubric of, did I remember to think about this and these kinds of things. I love it when I put together a rubric for my students, and it has, if you want an A, you get this. If you want a B, you get that. You know, this is a different kind of rubric. It's more of a matrix for understanding the whole tool, but it will make a significant difference. This is your Where is Waldo moment to kind of remove the clutter and figure out what it is that you might be seeing and have missed potentially in the past and don't have to miss it anymore. Thank you for your time today. Appreciate you having me come, and I'm glad to help you along this journey.
Sure. Sorry, go ahead and take that off.
Hi. Oh, she's kicking. Okay. Hi, everybody. My name is Zachary Zoet, and I serve as the Assistant Director of the MSU Counseling Center, and I'm also an adjunct faculty member in the Psychology Department.
I'm Ashley McErlean. I'm a LMFT in private practice. I'm also an adjunct instructor at a few different universities, and I run the Opal Center, which is an LGBTQ resource center in Wichita Falls. Do you want to, am I starting or are you?
Yeah, I can go.
Okay.
So today we're going to talk to you guys about a couple different things. We're very excited about this presentation because we believe that you guys are where precisely you can do the most good for people who sometimes have not had a lot of good done for them. And so we're going to be talking to you guys about how to utilize appropriate language and understanding terms like gender, sex, gender identity, gender expression. We're going to discuss some specific takeaways that you guys can bake into your practice, whether that looks like you're a PNA, you check vitals, hand out pills, you're doing therapy yourself, medical treatment. We want to give something for everybody. And so we'll try and give you guys some things you can take away. And then obviously we'll also link you guys to some resources.
Okay. So some of the specifics that we're going to go over is appropriate language, you know, offensive terms versus non-offensive terms, what the terminology you hear might mean, because I know a lot of words are thrown around and not everybody is really clear on what that actually means. And then we're going to talk about gender-affirming care, which is kind of a newer concept that has been gaining ground in recent years. So we're going to talk about what that is and how to become a more gender-affirming clinician. And then, as Zach said, you know, get you started with developing a list of resources.
Okay, so we're going to get started with some of these core concepts. So the first thing that we're going to talk about is sex, gender, and sexual orientation. So sometimes when I'm doing an intake interview with my clients, I will ask them sexual orientation as an intake question, and sometimes they'll kind of stare at me, and based on where they're from, sometimes they don't really understand what that means, and they get a little bit confused. And that's okay, because every day we're learning new things, and for some of y'all, today might be the day that you have this spelled out for you, and that's okay. You're not behind, you're right on pace today. So first thing we're going to talk about is sex. So sex is the biological classification of being female, male, or intersex. This is the biologically rooted components such as chromosomal changes, abnormalities, hormonal changes, abnormalities, and that phenotypic expression that we learned about in school. So a lot of times when we're thinking of male and female, we have a very clear-cut box that we put male in and that we put female in. And studies are actually suggesting that this boxing and this binary is not actually serving our clients very well, and it's also not actually grounded in reality. So I'm going to bring up a very notable example that people in here might know about. So just from a show of hands, who has heard of the Olympic athlete Caster Semenya? Okay, so I see a couple hands. So this was a pretty famous controversy recently wherein an individual that was assigned female at birth, well, she was competing with other athletes, and her phenotypic expression, well, her shoulders were broader. She was more muscular in certain areas, and they did genetic testing on this individual, and they found that she produces testosterone at levels that are outside of 1.5 standard deviations from other assigned female at birth persons. And so individuals like this embody that kind of intersex area where you have expressions biologically of, it could be chromosomes, hormones, etc., that are not consistent with what one would typically expect from that sex, right? And so we used to deal with that by doctors on delivery kind of looking at the genitals and making a best guess. And as I'm sure a lot of you know, that wasn't necessarily the best practice for those individuals, because a lot of times they would grow up with confusion surrounding their gender identity, and there are very notable examples that ended tragically in being studied for decades and then culminating in a completed suicide. And so we really want to underscore with you guys that biological determinants of sex are not as boxy as previously conceptualized. So next thing, actually, Ashley, anything to add on that?
And actually I will. So I like to use a lot of personal examples to kind of illustrate what we mean. And maybe some people in this room, I have a condition called PCOS. And if you've heard of that, that is technically considered a disorder of sex development. So hormonally, I would not go all the way to where a typical female would sit. So I produce more testosterone than a typical female and have some side effects as a result of that. It's a pretty common disorder, but it's kind of an illustration of this idea that, you know, we're not one or the other. We can fall anywhere in between. So maybe I'm like right here. Other people have chromosomal and hormonal differences that might put them closer to the middle, and anywhere on that spectrum. So.
Yeah, another great example. So next concept we're going to talk about is gender. So gender is something that's separate from sex physiology. Gender is best understood as a social construct. So individuals that are familiar with developmental psychology, there's lots of different prevailing theories on how we develop our sense of gender. There's gender schema theory that basically suggests that what has been modeled as male for you and female for you, you want to rise to meet the expectations of. And just to give an example of perhaps prevailing cultural norms a couple decades ago, that would have looked like women embodying certain roles, whereas men embody other roles. And this was the status quo, and it's kind of what people rose up to meet. Now, obviously, we want to kind of contextualize that a little bit, and in different cultures, the same schema-based theory of gender development looks differently. For example, you might see qualities like assertiveness, brashness, forthrightness, impulsivity. You might see those as male-coded traits in, I don't know, America. But if you go to different cultures where perhaps they're more, I don't know, matriarchal in orientation, then, I don't know, sometimes femininity in those cultures ends up looking a little differently. And these females that are more brash, assertive, bossy, or some other unfortunate B word just because they're expressing themselves, it's not experienced in that way in that culture. It's a pro-social, pro-gender behavior. But as with anything relating to culture, context is key. And so what I always tell my students in my developmental psych courses and in my multicultural courses is you can never divorce a client or patient from their context, because they will always be carrying their experiences, their culture with them when they walk into the room or interaction with you. And you cannot hope to make sense of them from your formulas and your culture without acknowledging the role that their culture has contributed to developing the person that sits across from you. And so there are other gender-based theories like cognitive theories, there's moral-based theories, and basically, like to give another example, it's small moments of gender policing on the playground where if a boy cries, well, peers are gonna jump on that and say, that's not very boy-like, or boys don't wear that, girls don't wear that. That's an example of the cognitive theory of gender development. And so your culture, your experiences, your society very much informs what maleness or femaleness looks like for you, and in it expressing so differently based on where you're born, located, etc., that kind of underscores the point we're making here, where it's not quite so fixed as some people suggest it is, because holding hands with a male friend, one of the manliest things you can do in Turkey or somewhere like that, because that signals a secure paternal or friendship-based bond. Here, depends on the person, place, time, right? But again, that kind of underscores how maleness doesn't quite have to look like our perspective of maleness sometimes, and it needs to look like us inhabiting what maleness looks like for our clients.
And I'll add on to that. Sometimes our cultural context ends up being more powerful than our beliefs about something. I have very strong beliefs about not forcing gender norms on my kids. I have 2 girls. And yet I catch myself when they're wearing dresses and being rowdy saying, hey, act like a lady when you're in a skirt, right? And so I'm enforcing that gender norm that ladies wear dresses. And I try to catch myself on these things, but it just highlights the fact that our culture is very ingrained in us. So even if we hold strong beliefs to the contrary, sometimes those cultural discourses come through in our behaviors and our biases and things like that. So being aware of how your culture influences how you're approaching certain clients is really important.
Yeah, for sure. And that's kind of our first $10 SAT word of the day, which is ethnocentric monoculturalism, which is when you feel like your culture and what you've experienced culture as is the right culture, and then you police and expect people to inhabit that. And this is outside of gender-related specifically, but it could look like a client who's consistently late to sessions, and you, having been very sensibly groomed in a Western-centric psychology program, you're gonna view that as resistance, right? You're gonna be like, oh yeah, what we were talking about 2 sessions ago with Dad, oh, they don't wanna talk about that. That's what we need to talk about. Really, they might have a present orientation towards time rather than a future orientation towards time. And that might be grounded in their cultural context. But if I'm using what I expect time adherence to look like, or what I expect male or female adherence to look like, I'm gonna effectively harm my client by trying to impose my beliefs and values on them, or make them fit my square shape when they might be a round shape. And as mental health professionals, we're kind of stewards of helping our clients rise to the level of who and what they're meant to be when those barriers are removed for them, you know? And another example with gender is, and we'll talk about this here in a beat, but androgyny, we're very comfortable with androgyny historically. We just haven't really called it that. These are people like our David Bowies, our Elton Johns, our Liberace's. We've seen androgyny and blurring that boundary before, but if it doesn't look like the context we're comfortable with, sometimes that challenges us, you know?
And I'll jump on there too, and we are going to talk about this a little bit when we go into gender affirming care, but one of the traps that I've seen very supportive and gender affirming therapists do is, okay, I fully support that you identify this way, so let's talk about how to be more of the gender you say you are. And so pushing people toward our ideas of what it is to be a man or a woman, non-binary or whatever, is another form of, it's like the other end of that. I'm going to be so supportive, but I'm still imposing my beliefs. So that's, it can go either way.
For sure, and that's one that well-meaning clinicians have to be very mindful of, because you want to help see a future for your client, but maybe your cookie cutters of what a trans woman looks like are not actually this person's unique trans experience. So next thing that we need to talk about is sexual orientation. So sexual orientation refers to the inherent and immutable emotional, sexual, or romantic feelings, I was reading yours, towards other people. So obviously this exists on a spectrum, because spectrum is our word of the day up here. So you have individuals that are gay, straight, lesbian, bisexual, pansexual, asexual, and this is a construct, as I said, that sometimes we need to really intentionally uncouple from the ones that precede it, because it's its own independent thing. And to underscore this, I always bring this up in my courses. If I have a client who identifies as bisexual, my first follow-up question with them is always, oh, well, do you experience similar levels of sexual and romantic attraction to both men and women, or whatever they're attracted to? And that kind of denotes that breakdown of sexual attraction versus romantic attraction, because not every client who's bi needs to experience a romantic attraction to two or more genders. They can just experience a sexual attraction there. And that underscores that orientation itself falls along different lines.
And so talking about theory, so our theories about sexual orientation have also grown and expanded over the years. And I'm sure many of you in your human sexuality courses learned about Kinsey and the Kinseyan scale, and you're a 1, 2, 3, 4, or 5. I know when I went through college in the early aughts, I was putting myself on one of those numbers. Over the years, it moved toward a spectrum understanding where we can be kind of anywhere and we can move back and forth on the spectrum between gay and straight. And in very recent years, we've kind of moved away from the spectrum even and into an understanding of a continuum, because having a certain level of attraction for the same sex as yourself, same gender as yourself, does not mean that you have less, right? So the spectrum says, okay, if I'm this far on this end, then I'm over here. So if I like men this much, then I only like women this much, which is not how it works, right? So a continuum idea is, okay, I'm attracted to this gender this much, I'm attracted to this gender this much, and it allows for more flexibility in how we view our sexuality. And that's kind of where our field is going in our understanding of sexual orientation.
Mm-hmm. Yeah, that kind of underscores that we're trying to be very nuanced and client-centered in inhabiting the world that they step into the room with. Next slide.
Oh, that's my job.
Oh, are you doing it?
Yeah, I forgot.
Nailed it. Okay. All right, so next thing we'll talk about is gender identity. So gender identity is an individual's internal, deeply held sense of being male, female, neither, both. It inhabits that spectrum-based understanding of maleness, femaleness, and what that looks like for the individual. For the vast majority of persons, their assigned sex at birth correlates with their gender identity. However, it doesn't necessarily have to. And individuals can inhabit a consistent sense of identity as female, male, etc., while still exhibiting a lot of traits, features, characteristics that would be keyed to maybe the opposite gender typically. You'll see a way that that's accepted in our culture through tomboys, for example. Tomboys are allowed to inhabit a broad spectrum of gender expression and gender identity without it necessarily undermining their sense of femaleness, you know? And sometimes for men, there's little less leeway there in our culture, but essentially here you can see lots of different examples of a gender identity. And the first slide, the first bullet is pretty essential for me because it underscores that you can have aspects of maleness, femaleness, or you can not identify with those features whatsoever. And this is perhaps best exemplified with the term androgyny. So if somebody's androgynous, they are expressing features consistent with maleness, femaleness. To give you an example, moi. So depending on the day, context, I don't know, I can exhibit certain features that are consistent with maleness, but I also have some features, traits, expressions that are, I don't know, a little more feminine coded. But that's kind of the expression of both. But then you can have individuals that are a little more neutral or not given to male coded or female coded expressions. These are individuals that don't carry with them those types of features, nor do they desire to. And that is a persistent gender identity for the individual. And so when we're discussing gender identity, again, it's not our place to try and police the client or where they inhabit or make it make sense for us, because for them, when they walk into the room with you, they're bringing their world with them, and it's on us to not try and make them fit our world, our rules, our expectations. The expectation is that we create an environment where we can have that safety and trust, where they'll show us how they're ticking, and that includes how they're relating and expressing themselves in the world around them.
And, you know, you guys have worked in this field probably long enough to see that there are more and more young people now who are kind of rejecting the whole idea of male and female. Lots of kids identifying as non-binary, agender, trans, whatever. There's a lot more, because I think our society is allowing more space to explore that. And a lot of these kids will eventually settle somewhere, and others won't. And I think we're, again, as a culture, moving toward a place where that's okay. And so we're going to see more and more of that. So knowing and having a grasp on this language is going to be helpful when you have young people coming in and using these terms to describe themselves, because it's going to be happening more and more frequently.
Mm-hmm. Yeah, I'll just say over the last couple of years, even more and more, I've had clients who are identifying as non-binary. And that, if somebody tells me they're non-binary, well, one, that tells me a lot about how they're experiencing themselves and how they're moving through the world, if they're willing to use that label. And then secondly, it means that I need to create a good space to figure out what non-binary looks like for this person. And so allowing our clients to use their preferred gender identities where able, allowing our clients to use their preferred pronouns, that's mental health care.
Right. Oh, you go back.
So gender expression, I brought up this term earlier. So this is basically how people express their gender. So gender identity is an internal thing, but how people, I don't know, just for example, people's personalities and how they express their core values, their beliefs, etc. There's as many expressions of that as there are people, right? And so gender identity is something that's an internal framework, but gender expression is how that is carried through the world around them, and how it looks like the way that they talk to you, the way that they dress, their pronouns, their voice, their body, their haircut. Like, for example, for me, I mean, I'm playing boy pretty good today. I've got my short hair, I've got my male-coded clothes, and I'm expressing maleness, right? And so that's an example of gender expression. However, you'll have clients, maybe not in the settings you guys work in, but sometimes in my setting, I'll have a client who comes in expressing maleness one week, femaleness another week, androgyny another week, and then nirvana punk realness the fourth week. And you know what that tells me is that this person is being given an environment and permission to show up as they are. And that really gives me information to figure out how to better connect with this person.
And a good example of this, I tend to use my mom a lot as an example of this. So this is a woman who has a very strong internal sense of being a woman and female. So she would be what we call cisgender, but joined the military in the 1970s and as an officer. And you know, went through the ranks and retired as a lieutenant colonel, and in order to do that successfully, had to exhibit a lot of male-coded traits. Assertiveness, her communication style had to be probably different than what was natural for her in order to succeed in that environment. So our gender expression sometimes also adapts to the environment that we're in and is created in order to survive the life and the context that we have.
Mm-hmm. Yeah, really important. Okay, so we wanted to punch on some specific key terms. I feel like these have entered the popular lexicon pretty well, but we'll just hit them again. So transgender, This refers to an individual whose gender identity differs from the sex assigned at birth. Some studies suggest that 0.3% of the population identifies as trans, but more recent studies indicate this may be a conservative estimate. Gender dysphoria, this refers to a constellation of symptoms, cognitive, physiological, etc., where it's discomfort or distress caused by a discrepancy between gender identity and sex assigned at birth, or them experiencing their physiology as not being consistent with their gender identity, etc.
And this is our diagnosis at this point in the DSM. This is what we diagnose when somebody expresses these experiences.
Yes. Next term, cisgender. This is the term for an individual whose assigned sex at birth matches their gender identity. For our pharmacists in the room, this is terminology you'll be familiar with because cis refers to on chemicals when the isomers are on the same side of the chemical, and then trans is when they're on opposite sides. So this is language that's been adopted from chemistry, science, etc. It's not a new term. It's just been used to match that one-to-one of sex assigned at birth with gender identity. So if you have trans, naturally you have cis. Genderqueer, gender non-binary, these are individuals that don't identify with the male-female binary. They may feel that they inhabit a middle place. They may feel that they don't inhabit any place. And this is an example where the language that a client uses with you really underscores their cultural background. And so to give you guys an example that's outside of this context, I work in higher ed, and so sometimes certain stereotypes about higher ed are accurate, and other times they're not. But to give you guys an example, sometimes I will get emails from people that has the word folks on it. And when I get that word sent to me, sometimes it might say F-O-L-X. Now, when somebody says to me folks, and they spell it in that way, that tells me a lot about them, their cultural context, where they're coming from, what they want to communicate to me explicitly about themselves and their values, and the space they want to create with me. Same thing if somebody sends me something that says women, and it says W-O-M-X-N. From the jump about how they're experiencing themselves, what they implicitly, in a way, expect from you sometimes, and it opens the door for you to have conversations with them about what this label looks like for them and how they came to it, you know? Intersex, we hit that one at the jump. And then gender transition, this refers to, oh boy, it's the start of the marathon, but refers to the processes through which people seek to align their external manifestations of gender with their internal understanding of their identity. This includes social, legal, political, medical interventions. It means changing gender markers at the DMV. It means having conversations with gender-affirming providers about the role of hormones. It looks like discussing with people about different procedures, or it looks like literally none of that, because everybody's trans experience and how they move through that doesn't have to be stereotyped, because there's no one right or realized way to be trans.
And that's another example of the tendency of some professionals in our field to push people toward what they think is an appropriate expression of transness. So the idea that when somebody sits down in front of you and says, well, I identify as a transgender woman, the assumption that they want to then do HRT and have surgery and change their name and things like that, there's this expectation that a lot of people in the field have, oh, this person wants to transition, and that's not always the case. There are some people who just want to identify, but it maybe would cause too much fallout in their lives to pursue any kind of medical or legal transition. Or it might be that they're perfectly comfortable in their body. They just want to acknowledge who they are as a person. So it's our job to not impose those ideas of what their next steps should be and just listen to what they say they need.
Mm-hmm. And that's kind of a running theme of our presentation is chill, listen, and even if your intentions are good, don't let your good intentions realize themselves as gender policing within session and pushing somebody towards something that maybe they don't even really want.
Okay, so we have a short video, and it kind of goes over what we've said, but he does it in a very excited and interesting way that I don't think Zach could probably match. I don't think I could match, so I prefer to just let someone else do it. But it just kind of talks about how these different identity factors interact with each other to, create all of these unique identities that we will encounter. So I'm pointing, but there we go.
So that's probably even worse. The best and maybe only way to solve this problem is for people to understand that there are no nice shiny boxes. Or if there are shiny boxes, there are
this is the end.
Enough to put all of the people who currently
This is the end. Can we rewind?
It will ever exist. So together, let's understand. We're gonna start simple. What's going on down here in between the legs?
Okay.
You guys started it in the middle, I think is what she's saying.
No, it's good now.
All sorts of conditions that result in intersex individuals. And as interesting and complicated as this is, the rest of it is much more
It's good now.
complicated.
It's okay. It would be a conference without a technical issue, right?
They started it over. It was good. They're good.
Move on from here.
Yeah.
'Cause we all kind of get what sex is.
There we go.
Walk over there.
And now we move on.
Are you at the computer?
Up to the top.
This video was causing us problems earlier, too.
Oh, and that's probably even worse. The best.
We'll just have like a little deliberation.
They could probably start it from this point, and it'll be
Okay, so we'll just roll with it. Okay, we'll go with it. Just press play. We'll make it work. What they missed, we'll talk about.
Maybe only way to solve this problem is for people to understand that there are no nice shiny boxes. Or if there are shiny boxes, there are an infinite number of them, enough to put all of the people who currently exist, have ever existed, and will ever exist. So together, let's understand. We're gonna start simple. What's going on down here in between the legs? That is your sex, your biological sex, and it tends to be binary, though there are all sorts of conditions that result in intersex individuals. And as interesting and complicated as this is, the rest of it is much more complicated, so I'm just going to move on from here, because we all kind of get what sex is. Now we move on up to the top, to the brain, which is the thing that decides what gender you identify with, whether you feel like a man or a woman, or neither, or both. Because the fascinating thing is, as much as we try to label things, there is no way to label every point on an infinite continuum, and that's what we're dealing with here. So, to actually visualize how this works, I've created a graph for you. On the x-axis, we have gender, male to female, and on the y-axis, we have the intensity of the identification with that gender. I would be about here, because I identify as a man, though I recognize that there are some womanly parts of me. But let's also put a hypothetical biological female on the graph that identifies very strongly as a man. Now, that can be really uncomfortable, especially when there's a bunch of people in the world who insist on calling him a woman just because of the body that he happens to be very uncomfortable with. Which is why sex does not determine the pronoun you should use. Gender does. Now, moving on to your heart. Your metaphorical heart, of course. It's who you're attracted to. Men, women, all genders. Again, it's a spectrum, and that spectrum includes intensity, because there are people who don't feel strong sexual attraction at all. That's why asexual is a sexual orientation. A newer idea that I was happy to be exposed to yesterday on Tumblr is the idea of romantic orientation. These are the people that you want to have strong, intimate relationships with, but it sort of separates out the idea that sex has to be the goal or end point or like end all and be all of every intimate relationship. Now that we've dealt with how we feel, let's deal with what happens when other people actually get involved. That's sexual behavior, which is actually very different from sexual orientation. And that might seem a little bit strange at first, but it's not. Consider, for example, a heterosexual priest. priest. That priest's orientation is heterosexual, but because of his religion, his behavior is celibate. Here we're not talking about the preference, we're talking about the behavior. Now, built on top of all of this are gender roles, which are built by societies, not by individuals. The obvious ones are masculine gender roles and feminine gender roles, but as all dichotomies are false dichotomies, this one is a spectrum too. Now that we've sort of gone over all of this, it's important to note that every single one of these categories is independent from each other. So a biological female can be a man who only has sex with women despite the fact that he's attracted to both men and women and kind of, feels more comfortable in feminine gender roles. That may not be the most common combination of these factors, but it's certainly not weird. Another important point, many people move across these spectrums, sometimes from year to year, sometimes hour to hour. But what's really important is that we trust ourselves, and we understand ourselves, and we love and respect ourselves, and we grant that same understanding and respect to the people around us. Because when the world becomes one of infinite continuums and those false dichotomies break down, and those 2 shiny boxes break apart into 7 billion shiny boxes, it's actually pretty beautiful. John, I'll see you on Tuesday.
Okay, so that was at least on our end. Could you guys hear that okay out there? Okay, brilliant. So I guess the first thing I want to say is, Ashley, I'm so thrilled the camera was on you that entire time instead of me.
I didn't love it. Every time I look back and see my profile, I'm just like,
yeah,
oh,
I was
man.
like, better you than me. Okay, so here's a nice shiny little example that was supplied to us by TSER, and this kind of underscores the movement away from that kind of number line binary into expressions of characteristics and factors. Because when there's expressions of characteristics and factors, it does not necessarily inherently take away from femininity, masculinity, etc. And so this is actually a more three-dimensional and fluffy way of looking at this. So at the top, you can see gender identity and little variables related to that. You can see gender expression, you can see sex assigned at birth, physical attraction, emotional attraction, and this movement of the expression of, rather than trying to accommodate, that you see a lot of times in those number line models.
Okay. And this gender unicorn is something that you can find online and use with clients if you feel it's relevant. Okay, so I'm going to take over for a little bit and talk about the problem. So basically, why are we doing this presentation? Why are we talking about this issue? And the reason is because LGBTQ in general, but gender-expansive people specifically experience a lot of disparities in healthcare. There are a lot of barriers to accessing competent care, especially mental health care. Well, I say especially, but medical care as well. And there are a lot of experiences of microaggressions and discrimination and things like that. So this presentation is one of many that it will take to bring our field to a place where, you know, everybody is receiving equal access to quality care. And we'll talk about a little bit of what we've seen. So some of the reasons why we need quality care for gender-expansive people is because there are a lot of negative outcomes within this population. And that's not because this population is more prone to mental illness. It's because this population experiences a lot of environmental and cultural factors that increase the likelihood of experiencing mental illness and other negative outcomes. So more than 60% of trans individuals exhibit symptoms of depression, which when you're constantly living in a world that doesn't accept you for who you are, that makes sense. 41% of trans and gender-expansive adults reported past suicide attempts, compared to only 4.6% of the overall population of the US. So that's a huge disparity between the two. 20 to 50% of male to female trans people experience a major mental illness, and up to 62% report a history of substance abuse. So you're going to see gender-expansive clients come into substance use treatment facilities, into the state hospital, all different settings, and they need people in those settings who are competent to work with them. And then LGBTQ in general are at increased risk for HIV, substance use, mental health disorders, often as a result of stress related to discrimination. And family rejection, which is a key element in a lot of what we see. And I'm not going to read all of these word for word, but discrimination and bullying is also still a major issue in the U.S., especially in certain parts of the U.S. There are areas where this is less likely to happen, but I don't think there's anywhere in this country or in the world that's completely safe. And this still happens with our kids. I would say that the generation of kids coming up through school now is one of the most tolerant and accepting and open-minded about things like gender identity, sexual orientation, but bullying is still a big problem in a lot of our schools, especially bullying related to these identities. And I think you'll get these slides so you can have all of these statistics, but I just wanted to make sure they were on there. So, another big issue is workplace discrimination. That's something that's encountered a lot. I have a lot of gender-expansive clients who've been fired or passed over for positions once the interviewee discovered that they were trans. And that is not an uncommon thing, especially in this area. And I've had people who've gone through transition only to be kind of pushed out of the workplace or outright fired, because in this state that's allowed to happen. So what we really need to talk about with this group is the disparities in health services. So research shows us that in medical care, a lot of gender-expansive people will avoid seeking out medical care because of past negative experiences of being discriminated against, feeling like they're being judged, dealing with microaggressions, not having their concerns taken seriously. All kinds of horror stories out there. And that's compared, 23.5% compared to 4.4% of cisgender LGB. So people in the LGB community, but not gender-expansive, are much more likely to seek medical care. Trans people say they often feel pathologized, which means they feel like they're being told because you are gender-expansive, you are sick, invalidated or told that their identity is not real, and mistreated in therapy. Another big issue is that clinicians often conflate mental health concerns with gender identity. What that means is a gender-expansive person comes in and says, I'm depressed, and you say, well, it must be because you're trans. And putting those two things together and making them inseparable. Well, you know, you have these problems because of who you are, when that is often not the case. And then LGBTQ in general, individuals in mental health settings often report encountering heterosexism, homophobia, transphobia, and discrimination from staff and other patients. So that's another thing to consider, is how are we protecting the safety and well-being of our gender-expansive patients in terms of other patients in the facility, and our staff members who maybe are less educated on the subject. So we have a short video from a young trans person who was in inpatient care, and they recorded this video to talk about their experience while in inpatient care.
Hi, so long time no see, it's Jack again, and
Maybe.
I took a break because I went south for high school, and I want to talk about something that happened over the summer that I just decided that I should probably share to let people know. So in early July, one thing led to another, and I had a suicide attempt, and I was arrested, and I was taken to the local psychiatric hospital. They usually take depressed people, violent people, people who have attempted suicide to these hospitals, so that's where I ended up. And I came in at about 10 o'clock at night, and so one of the first things they asked me was, well, obviously, what's your name? And being that I'm just 16, my name on my birth certificate or ID has not been changed. So when I told them it was Jack, it became apparent that there was some sort of, discrepancy between those two. So, they didn't like the transgender thing. Being that the hospital was in Texas, no one really likes that stuff here. So, I'm basically going to describe the, frankly, really bad conditions and what it's like to be a transgender person in the mental health field. So, what I would like to warn everyone about before I discuss it is that I'm about to discuss something that relates, is sexual assault. So I'll put down in the bottom when you can skip to if you would not like to hear about that. So one of the nurses was slightly curious about this condition, and I didn't read over the rules. I was kind of panicking, and I was taken into a dark room by myself, and I was told to take off all my clothes. I said no, and I was told that if I did not comply, I would be in trouble, and that it was the rules of the hospital, and that every patient had to remove their clothes upon coming in to check for, knives or anything that could be used to harm yourself. Like they said, it was a safety procedure. So basically, I thought maybe I just have to take it off just to my underwear so they can see, are you carrying any knives or weapons? And I had to remove everything so that she could see my genitals. A lot of the questions that I've heard transgender people being asked is basically, what's going on downstairs? And basically this nurse took it upon herself to answer that question and abuse her power as a medical assistant. And when I asked all of the other patients, they reported to me that I was actually the only one who was forced to take off their clothes. One big coincidence that happened at this hospital was that later in the night, another trans guy actually was assigned to be my roommate, which is kind of odd because I've never met another transgender person in my life. So during our stay at this hospital, we endured a lot of harassment from the nurses. For example, in mental hospitals, you have therapy and you have group activities to keep yourself occupied so that, during rest periods you can't spiral into depression or anything dangerous like that. So during these activities, we would be assigned one tech after another, and you would have to introduce yourselves to the techs. And they would look at my name tag and they would ask me my name, and I would say Jack, and that's not what my name tag said. And it became to the point that they would tell the other nurses that there was a transgender person in my unit, and they would say everyone has to introduce themselves by their birth names. And they would try to trick me into telling them my birth name, how to pronounce it, because, I'm from Pakistan. I have a really long, complicated birth name. It's really hard to pronounce. And they would try to be like, oh, where are you from? How do you pronounce your name? And I would just trying to trick me into pronouncing it so that that's the name they'll call me by. As for the other trans guy, they did not call him by his name. He would insist his name was Ryder. I would say my name's Jack, and they would be like, no, it's not. No, I'm not going to call you that. And at one point, both of us got locked out of our room, and there was a nurse watching over a child across the hall from us, and she watched us try to open the door, and she made a comment to me, and she said, if you were a real man, you would be able to open the door. And it has nothing to do with anything, to be honest, and she was just, being really rude. I don't know if you require a dick to open a door or something, but a lot of the nurses went out of their way to make it clear that they disapproved. Like, I would be teasing a nurse, and I would be like, oh, you're such a poser, you're wearing Vans. And you'd be like, you're the real poser here, and I'm not going to say it, but we know why, as in, you are posing as a male when you're not. And the treatment of some other kids was pretty bad. For example, when they told this one nurse that I was transgender, he got really angry at me and my roommate, and he separated us. And he said, the reason you are in this hospital is not because you tried to kill yourself. It is because you're transgender and you need to be fixed. I've endured a lot of treatment like this, and so far that was the worst. I haven't reported all the incidents that happened in the hospital, but I reported the sexual assault last week. And I just would like to tell anyone that if this happened to you or you know of anything similar, if you could please tell me, and if you haven't already, please report it, because reporting it is honestly the first step to stopping all this and making sure that when people are in such a time of need that they need to be entered into a psychiatric.
Okay. There's a lot of feedback here, so that was around the end anyway. So this is obviously through the eyes of a 16-year-old, a young person, you know, so maybe not the most eloquent, but a lot of the things that he described were things that we've talked about that a lot of gender-expansive people report in mental health care. You know, having their pronouns and name ignored, being told that they are sick because they're trans, you know, having their gender identity invalidated. You know, if you were a man, you'd be able to do this, that kind of thing. And we like to think maybe that that's something that won't happen at the facility that we work at, but not everybody shares the same ideas or the same values, and so there are people who might be doing these things and you're not even aware. So I think it's important to kind of be watching for that and be an advocate for your gender-expansive patients, and making sure that other people are also holding professional standards, because there are guidelines within our field about how to treat gender-expansive people. So,
yeah, and I think Ashley did a good job of kind of contextualizing the video, but irrespective of the historical accuracy of every piece of that, I think everybody in here can pretty firmly question whether or not Jack really got the care that he needed at that time, or if there were systemic barriers that got in the way of his treatment and prompt discharge back into society, you know? So the next term, that's our SAT jargony term that we want to introduce to give you guys some teeth to what we've been talking about, is the concept of minority stress. So minority stress refers to chronic elevated stress levels in stigmatized minority groups. This could be due to poor familial support, lack of access to insulating generational wealth, prejudice, discrimination, baked in issues such as if I go to my doctor, they're going to ask me a whole bunch of questions about my parts, pieces, rather than why I'm here. They're going to make it about that. And that's inherently stressful because you have to push back past that and overcome that, and then assume that they're going to have goodwill towards you. So obviously, chronic elevated stress levels are correlated with HPA axis dysfunction. That's the hypothalamic pituitary adrenal axis. And if you have chronic HPA axis dysfunction, that leads to increased illnesses. It also leads to a bunch of symptoms like anhedonia, fatigue, insomnia, restlessness. What do those all sound like symptoms of to all of my mental health professionals here? Yeah, that sounds a lot like depression, right? And if I'm not contextualizing my trans client, well, I don't know, I need to rule out the role that biological factors or chronic stress-inducing responses are having on this person. Are they just mentally ill or given to mental illness because they're trans? Or is there perhaps physiological underpinnings based on how they're navigating a system like Jack had to navigate that hospital? So we wanted to talk about some standards and best practices within the field. So Ashley, I'll start the slide and then you can pick up with me. So Ashley brought up the concept of affirmative care. So affirmative care signals a transition in our field from tolerance and tolerating people. That's a term that people based on your generation might be familiar with. But if I walk up to you and I say, I guess I'm going to pick you because you're closest to me, and I say, hey, I want you to know that I tolerate you. Well, that doesn't sound very rosy, right? And so we need to shift from tolerance and giving people the right or lease to exist near us, which is what tolerance means, to affirmation and affirming individuals. Because when I affirm you, I invite you to the conversation. I see you where you are, and I try to affect, as best as I can in the context of where y'all work, I try to affect a hierarchy that looks a little bit more equal, where he has permission to engage with me, and it's not an implicit message of you're deviant and I tolerate your deviantness. How magnanimous am I? And that's kind of that shift from tolerance to affirmation within our field. So, while Ashley's choking underwater, I guess I'll keep it pushing. So, one thing that we strongly believe as proponents of gender affirming care is that you need to meet and invite your client as they are, and that we need to be advocates inside and outside of a therapeutic space, and that you need to try and get connected with different organizations that can help advance that cause.
Okay. Sorry, I've got some allergies going on, and they...
She just got COVID tested, and they promised us they'd yank us off the stage, so she's good.
Okay, so, boy, crying and everything. So the standards of the field are toward, oh boy, and my voice just went away, are unanimously gender affirming. So all of our professional organizations, APA, AMFT, ACA, they all hold the stance that we should be gender affirming when we work with gender expansive clients, or LGBTQ clients in general.
That's also in the APA professional ethics as well.
Yeah, so it's in the Code of Ethics. There are actually competencies that have been created specifically to work with gender expansive and LGBTQ clients. And so basically affirmative care embraces a positive view of LGBTQ identities and relationships and addresses the negative influences that homophobia, transphobia, and heterosexism have on the lives of these clients. So what that means is when somebody comes in and says, this is who I am, we say, okay, this is who you are. And then we acknowledge that maybe the context and the world that they live in has not allowed them to be who they are and has had a negative impact on them and might be part of why they're sitting in front of us. So that's the basic definition of affirmative care. And our Code of Ethics and our competencies call on us to act as advocates for gender expansive clients. I think you said that. I know you're rescuing me.
You're doing great.
Oh boy. All right. So there are some competencies that have been put out by professional organizations, like I said. One of the most well-known when we talk about gender expansive clients is the World Professional Association for Transgender Health Standards of Care, and this talks about what medical, mental health, and other professionals are expected to provide to gender expansive clients. And this is kind of the guidelines that are used when insurance companies are approving things like transition-related medical care and things like that. They follow these guidelines. We started as a profession to move away from the idea of gatekeeping people and telling people, okay, you've met the criteria to go ahead and start HRT or get surgery, but insurance companies are still using the standards of care as presented in 2012, right? So we need to get them moving with us, but we are where we are right now. So some of the things that the standards expect therapists to do, therapists and counselors, is to assess for gender dysphoria, so basically use the diagnostic criteria to say whether or not this is present, provide family therapy and supportive psychotherapy, assess and treat coexisting problems like substance use, depression, anxiety, refer and provide the necessary documentation for medical services. So that would be things like our letters of support for HRT or surgery, which I'll tell you in my practice, that's a one-session thing. Somebody can call and say, I need a letter for HRT. I ask them some questions, and I give them a letter, and they don't have to meet some, 12-session requirement or something like that. Educating the public and acting as an advocate is what we're doing here, but also on behalf of clients. So I've had to call schools. I've had to call doctors and talk about some of my clients and say, hey, listen, we need to change the way we're approaching this person. And referring clients and their families to sources of peer support, which in our area, the Opal Center provides some of that. And we'll give you that information toward the end. And then the ALGBTIC, that's so hard for me to say. The Association...
LGBT.
Yeah, LGBT. Association of Lesbian, Gay, Bisexual, and Transgender Issues in Counseling is a division of the American Counseling Association. And they developed these competencies for counseling with transgender clients. And so the categories of competency are in human growth and development, so we should understand gender identity development and how that factors into normal human development. Social and cultural foundations, helping relationships, group work, professional orientation, career and lifestyle development, appraisal, and research. So these sound pretty similar to the competencies to work with any client, right? But these specifically talk about, all right, now take all those regular categories that we apply to any client and look at them through a lens of gender-affirming care and attitudes. It's starting to come back.
So becoming affirmative, what does that look like? Well, that's something that is a very personal journey because everybody in this room has a different experience with gender-expansive persons and the gender norming experience that we have in whatever culture you come to. But some general things that you can do is try and reflect on your beliefs, notice your biases, and try to actively control for those because it's okay if you have an automatic reaction or bias based on your experience or your cultural value. It's not okay if you affect that to create harm or try to cause your client to rise to your expectations of what you think maleness, femaleness, etc. looks like. Ideally, you would try and challenge those types of thinking within yourself and the professional circles you inhabit. You would try and know resources in your community. This one's big for social workers in the room. On discharge, if you have a culturally bound client, your discharge does not need to look like the cookie cutter peanut butter and jelly of every other client. It needs to look individualized for that person in their context. And whether that looks like faith systems for some of your clients or LGBTQ plus affirming resources for others, it's not actually walking the walk or providing good discharge if you're not linking them to services that you think in good faith will help this person to not come back into the state hospital, because the goal is that they realize themselves, they thrive, they actualize. And you want to apologize and own your mistakes when you make them. I had to do that just this week, and it didn't undermine my competencies. It made me a more credible clinician in this person's eyes. Small things that you can do is go to training opportunities like this one. Thank you. We're really glad that you guys are here. Include LGBTQ plus literature in places where appropriate, and that could, and this would be challenging, I'm sure, but if there are areas of your spaces that depict certain persons, like posters, or if there are leaflets or booklets that depict certain kinds of people, maybe examine if all kinds of people and all kinds of patients that you serve are reflected in that literature or those posters, because being affirmed in the materials they're working with, the group packets or the posters or things like that, that can go a long way towards making your client feel affirmed in that space.
And I'll jump in and, oh, hey, I'm back. You know, one of the things, and I have the privilege of being in private practice, so I get to set my own policies and procedures, make my own paperwork, and I know that working in inpatient might be limiting in some of those ways. But, you know, some easy things to do is to provide forms that don't ask male or female. They just have a blank line. You write in your gender identity. Same thing with sexual orientation, if that is something. It's not just gay or straight. It has a line where people can define themselves however they want to. And that can apply to any really diversity factor that you include in your intake paperwork, but these are, you know, obviously the ones we're talking about. The big one that I really like to emphasize is not asking unnecessary questions. So one of the things that we need to be asking ourselves when we're doing intake with somebody is, do I need to know this to provide adequate care for this person? Is this relevant to their treatment, or am I just curious? And the big one that this comes back to is questions about genitals and surgery and things like that, and what transition-related steps they've taken. Do we need to know that to provide the right care to this person? Or is it just satisfying our own curiosity? Because that's something that a lot of gender-expansive people run into, is being asked those questions when it's not actually necessary to treatment.
Yeah, for sure. And you put it a little nicer than sometimes I do, but it's almost that voyeuristic tendency to try and explore and figure out and overly sexualize a population that is more than just that aspect of their functioning.
Yeah.
So, becoming affirmative. Oh, sorry.
Yep.
Next one. So what is gender affirming care? So gender affirming care looks like meeting the client where they are and inviting them to create a shared space between you two that's grounded in mutual respect. It's inclusive and does not impress upon the client your rules for what gender expression or gender look like. The client is invited within the context of you to create that space and be the chief architect of it. And you, in your job with them, you're supposed to step into the world that they bring in the room with them. It's not to try and police this person to fit your expectations. And what I always tell my class is that every universe has its own rules, and gravity, as it looks like for me, is if I drop this, well, it's going to come down, right? But different universes, they might not have gravity that necessarily works like that. And based on this person's cultural context, I shouldn't expect them to fit my rules and expectations of gravity, and I shouldn't be surprised or upset or bewildered if it doesn't. I need to try and step into the world that they bring in with them rather than trying to make them fit my mold, my model, because if that's the case, then you're not actually meeting your patient and your client, you're meeting clay that you're trying to mold to make more compliant. And that's not really the terminal role of helping professions generally, as Ashley and I tend to see them as LMFT and LPC. So gender affirming care, global, multicultural, sex positive, which means that you don't betray a nervousness or discomfort about talking about sexual acts, habits, behaviors, etc. You need to basically act nonplussed, unbothered, and like...
I would even add it's a lack of imposing shame on the idea of sex, which has been historically an issue in our field.
Yeah, for sure. And you need to treat them with the same level of comfort as if you were having a heterosexual client talk about their activities, or somebody who had anatomy that was more consistent with what you've come to feel anatomy based on identity should look like. Obviously, you want to use a full wealth of therapies and styles. I know that you guys are sometimes limited based on your setting on what you can practice by, etc. But obviously, you want to modify your empirically supported treatments and modify them with the cultural context to create evidence-based practice. Because you cannot just apply an empirically supported treatment piecewise to a person where that might not necessarily fit for them and their context. And so empirically supported treatments are okay, but they have to evolve to become evidence-based practice, and that looks like context.
I would say when it says informed by family systems, earlier I mentioned a lot of mental health issues that we see within the gender-expansive community are related to things like family rejection and not being accepted or respected within family of origin or their community. So when we say affirming care is informed by family systems, it's recognizing the role that those relationships and that kind of acceptance and support plays in a person's mental health and well-being.
So we wanted to also talk about microaggressions today. So microaggressions are essentially brief, commonplace, daily verbal, behavioral, environmental indignities, whether intentional or unintentional, that communicate hostile, derogatory, or negative slights and insults towards members of oppressed groups. And we have different examples there on the screen, but it's best understood to kind of be death by 1,000 paper cuts, where microaggressions are pretty insidious because they almost demand extra resources from the victim, where they have to guess their reality and whether or not that actually happened in that way, and if that really meant what it meant, which forces them again to inhabit almost a reactive, less than orientation towards interactions with the majority social group. So we're going to talk about 3 types of microaggressions. There's microassaults. These are explicit and intended. They're verbal or nonverbal. An example of a microassault is, if you were really a man, you could have pushed that door open. Well, that's pretty unambiguous, y'all. Microinsults, these can be unconscious. These are verbal or nonverbal communications. These can be rude, insensitive, or demeaning. And then micro-invalidation. So these are oftentimes best understood as expressions of introjected societal norms surrounding how you're supposed to be, and they can manifest as communications that exclude, negate, and dignify the realities of oppressed groups. Now, microaggressions can be explicit, intentional, designed to hurt, or you can engage in a microaggression as a well-meaning person that's trying to help. Now, we would encourage you, if you notice a microaggression or a patient says, oh, hey, I feel like that was a little rude or pointed, we really encourage you to try and adopt a perspective where it doesn't become about your ego and defending your ego, and it becomes about collaboration and understanding. Because if I can listen to a client, hear them out, and they tell me, when you said this, I heard this, oh boy, that is a wealth of information that's going to help me take care of that person, because they might have heard me say that, and what I really said is this, but they're really hearing a shadow of dad or a bully in 4th grade or, you know, all those therapy things. And so hang with it, validate it, apologize, own your impact regardless of the intent, and then process it.
So there are some pretty common microaggressions within the LGBTQ community. And you know, we'll talk about that in a broader sense. But the 8 themes that are seen most often in this population is the use of heterosexist or transphobic terminology. So that would be the F word, the other F word. Boy, I don't even want to say any of them. But it can also be the terminology we use not even thinking about it. For example, asking a same-sex couple, well, who's the man and who's the woman in the relationship? So that's very heterosexist in terms of this idea that relationships only work if there's a man and a woman. Even if you're the same gender, one has to be in this role and one has to be in this role for it to be a functional relationship, which we know not to be true. So that's one very common one. Endorsement of heteronormative or gender-conforming culture and behaviors. I talked about this a little bit earlier, but pushing people toward, oh, you identify as a woman? Okay, here's how you should act. Here's how you should dress. Let's get you wearing some makeup. Let's, assumption of a universal experience. So basically, I've worked with one trans person, so now I know what every trans person goes through, and I'm going to treat them all the same way. That's a form of microaggression. I can't say this word.
Exoticization. That was not it. But I
always stumble over it.
I did want to build on something that you said just now. One truth that I always beat on in my classes is there are more within group differences than between group differences, which is to say that when you come to a multicultural sensitivity training or educational seminar, this is not Ashley and I basically doing sanctioned stereotyping 101. Each person that you interact with is still going to be different. And there are as many different ways to be male as there are men on the planet. And you have extremes of maleness, extremes of whiteness, extremes of blackness, brownness, etc. And we want to encourage everybody to just stay very grounded and mindful of the fact that there are more within group differences than there are between group differences. And if you really internalize that mantra, that will help you with that cultural humility component of letting your patient or client teach you about their culture so that we're not given to stereotyping just because we've worked with lots of trans people before.
Yeah. So that word that Zach said for me is kind of what he was talking about earlier with the over-sexualization of the LGBTQ community, and where when somebody identifies themselves as a part of this community, we immediately think about them in terms of their sexual behaviors, their sexual activities, their genitals, things like that. And they're an oddity. They're something to be explored, and we get very curious about it. And it's an uncomfortable place for a person to be under the microscope, and over-sexualized, because just like everybody else, that's only one aspect of their life and their identity. Discomfort and disapproval of LGBTQ experience. You might not be overt about your discomfort, but if you display certain facial expressions or body language when somebody is talking about, say, their relationship with a same-sex partner, or talking about their trans identity, then that is experienced as a microaggression. It's like, oh, this person thinks I'm disgusting, or this person thinks there's something wrong with me. The denial of reality of heterosexism and transphobia. And this is, I kind of equate this to when you see people talking about racism and you see somebody else say, oh, don't play the race card. Like, let's not make this about race, when it very obviously is. And the same thing happens with people within the LGBTQ community when they say, hey, this has something to do with my identity as a trans person, and somebody else says, no, you're just making it about something it's not about, which is invalidating. Assumption of sexual pathology or abnormality, basically saying that you're a sexual deviant, or there's, you have a mental illness because of who you are. And then the denial of your own heterosexism and transphobia. So we all have internal biases and things that we don't necessarily control. And I said earlier, sometimes our behaviors and actions don't reflect our actual values and beliefs. So sometimes those biases are things that we don't even know are there until they come out. The important thing is if somebody does point it out to you and says, hey, that thing you just said was pretty transphobic, being able to say, okay, explain to me how, and being able to hear that and internalize that and work on it is an important trait in any mental health clinician. But a microaggression would be blowing that off and saying, I'm not transphobic, so nothing I say is transphobic, which isn't. You can be not transphobic and still say transphobic things out of ignorance or unconscious bias.
Okay, so one thing that we wanted to do for you guys is give you guys some concrete boots, which is specific takeaways that you can integrate in your practice as you're working with your patients, and as you're sometimes, depending on what's going on, having to be an advocate within your circles in the workplace. So we looked at different studies that helped gender-expansive and LGBTQ persons generally handle microaggressions. And some studies came up with a specific kind of breakdown, and we'll go through each of them on the next slide. Next slide. All right, so this is text for ants, but you guys should have access to this, and I wrote it down on here just so that you have the specific punches and pieces when you're reviewing this later, and yeah, but I'll read it, don't worry. So here's an example of a microaggression. You don't look trans. So here's a way that you could empower a client or patient to handle that situation. Wow, I didn't think you were the kind of person to make assumptions about people. And this is an example that appeals to values. And this is a way that you can raise the awareness and understanding with this person that they just engaged in a value incongruent behavior. And it's a very nice way to induce a little bit of cognitive dissonance in the person, where they have to navigate the fact that they feel they are water, but they just did oil. And so this is a very helpful way of addressing it, is by appealing to somebody's values. Another example, someone asking to touch your breasts because, quote, they look so real. Example response, it makes me uncomfortable that you want to touch my breasts. It makes my body feel like a novelty to you. So this is a pretty clean-cut example of empowering your client to speak about their feelings on the matter and exercise some assertiveness. Now, depending on the client, you might have to work with them to do some emotion labeling and assertiveness training before it, but this puts plain that this was not experienced so friendly as maybe the intent was on the other party. Example, you must be good in math. Can you help me with this problem? Well, you can turn it on the other person and ask them directly, kind of to clarify what they're asking you exactly. And you can say, why would you assume that I am good at math? And in a way, you basically empower your client to get the other person to explain exactly what they're trying to say. And then that doesn't let them dodge the issue. And if it was an unconscious bias playing out, at that point, it gives them permission to notice that and apologize. If it was explicitly intended to hurt somebody, then, well, at that point, we're no longer operating behind the mask, and it's mask off. Another example of a microaggression, how do trans people feel about affirmative action? Reply, it's great that you're curious, but not all trans people have the same opinion on things. My opinion is blah, blah, blah. And in that way, your client acknowledges the request and says, I am Zach above all else before I am this aspect of my identity. And that's a very gestalt understanding that the sum of the individual is more important and greater than the constituent parts and pieces. And that's important for you guys to understand with your patients, is they are more than just trans. They are more than gender expansive. They are the entire person, and they might not hold those stereotyped views or move in those stereotyped ways through society. Another example, of course, she'll get the job. She's a minority. Example, it's actually harder for minorities to get those jobs. I read a study about it, blah, blah, blah. And in that case, you empower your patient to give information and be assertive in refuting this incorrect talking point. Being told that you speak English well when it's your first language. Example, reply, thanks, I've been speaking it since I was born, ha. And in this way, you send up the stereotyped microaggression with humor, and you basically underscore the ludicrousness of this person and what just occurred. Another example of doing this is somebody assuming that you speak Spanish because you look Hispanic. You can turn to a friend or a colleague if this was worker on worker microaggression city. You can turn to a coworker and say, apparently I speak Spanish now, who knew? And in that way, you could invite the client or patient to respond with humor. And so we have different examples of different ways to empower your patients to handle microaggressions through appealing to values, expressing their feelings through assertiveness training, emotion identification, getting somebody to explain explicitly what they're trying to say so that then your patient has, well, it's unambiguous and it doesn't force your patient to question their reality of, did they just mean what I think they did? Okay?
Okay, so we do have a little activity, and this is going to be difficult because you guys are very, very spread out. So what we're going to do is just kind of go over it together because I don't think passing out is going to work. But it's a little bit of learning to recognize microaggressions because a lot of these are statements. We're going to talk about some statements that I think most of us have even said in different situations that can be interpreted as a microaggression. Not all of these are related to gender identity or sexual orientation. Some of them are, several of them are, but I just wanted to give kind of a broad example because microaggressions affect all minority groups. So one that I have, well, fortunately not heard too much in my life, but one that I've heard said is you throw like a girl. So what is the message that somebody would hear when they are told you throw like a girl? There's probably a message about femininity versus masculinity and which one's better, which one's stronger, which one's more athletic. There's probably a message about whether or not you meet the norms for what is considered man enough. So there's a lot of messages that come through in that you throw like a girl. When we all know, logically, rationally, that there are plenty of girls who throw just fine. Here's one that I've heard a lot. You're very pretty for a lesbian, which obviously that comes across as like, oh, so people like you aren't usually very attractive, right? Which is a very backhanded compliment. And maybe that person is intending to compliment you, but they're doing it in a way that is more offensive. Kind of related to one that Zach said, but where are you really from? This assumption that somebody who speaks another language or looks a certain way is not really from the US. But what country are your people from? That's an embarrassing one to hear. You are so articulate can be heard as, you're so articulate for someone like you. People like you aren't usually so well-spoken or aren't usually well-educated. Even something simple like, and I would clarify this one, so how did your parents take it when you came out? That doesn't sound like an offensive question, but it implies that we assume that your parents didn't take it very well, or that there's a good chance that your parents didn't take it very well, and that comes from a place of, well, it's not really a desirable thing to hear that your kid is gay. So I would say, I want to clarify that one. If you ask that question of somebody that you know their parents probably didn't take it very well, that's you asking that question from a place of, I know this person's context. But if you just ask that question of somebody because you know they're gay, then you're assuming that their parents weren't happy about it. Anyone can succeed if they're willing to work harder. That can be received as, well, you're just lazy. You're not succeeding because you're lazy, and disregarding and invalidating a person's experiences of systemic barriers that might be in place. So a lot of these are things that we might have said thinking this is not a big deal, right? They're not offensive. I'm not meaning anything rude by it, but how somebody else might hear it depends on their context and where they come from and their experiences. And so if they say, hey, what you just said was really offensive to me, then we need to be able to hear that and accept that and say, okay, well, I'm sorry, and I won't say it again, and learn from it and actually follow through on that. One that I've heard quite a lot. So I identify as bisexual, but I'm also married to a man. And so one question that I've heard many times is, okay, so you turned straight again, or so you went back to being straight. And it's like, well, no, my sexual orientation has not changed. I just chose a specific person, and that person doesn't determine how I identify. That's just who I care about and who I wanted to spend my life with. And so, you know, it's not intended to be an insult, but to me it feels like one, because it's like, oh, so your identity is based on who you're with, which isn't true.
Yeah, because it's basically straight washing you to fit what's the most palatable and easiest to consume quickly to make sense of, which is inherently dehumanizing to the three-dimensional nature of all of us.
Okay. So that's, you know, we would have passed it around and had you guys like draw lines and all that fun stuff and talked about it, but that
It would have been great. Lots of fun.
Logistically, it's not going to work. So. Okay. So a little bit about the Opal Center, and we'd like you to, you know, when you get copies of these slides, the PDF, file this away for referrals for your patients. The Opal Center is based in Wichita Falls, but we do telehealth. We have counselors that are not even in Wichita Falls, so we can work with anybody in Texas. We provide free counseling, mostly through graduate student interns, but we do have some licensed clinicians that donate a few hours a week. And then psychological evaluations. We have a psychologist that works with us to do things like ADHD evaluations, depression, anxiety, things like that. We offer free support groups and social groups. Right now we have a social group for LGBTQ kids between 11 and 15. We would like to expand that to some older kids. We have online support groups right now for adults that they can get to through Facebook. We offer referrals to necessary resources, so we can give them names of doctors who can provide HRT, point them toward resources for surgery, legal name change, things like that. We do a lot of training and education for professionals and organizations, mostly mental health professionals, but we've also, Zach recently went and talked to a human resources organization. I've talked to child care workers, you know, so we will talk to anybody, school professionals, things like that. Public outreach and education, so we try to produce materials, educational materials that are available to the public. Right now, if you know anybody who works within a school system, we have safe space kits that we're giving out free to school counselors and teachers. And we offer sometimes financial assistance to provide people with chest binders, which can get kind of pricey after a while. So,
and those are really important because otherwise people get hurt with those homemade duct tape situations.
Yeah. And we do have plans to expand some of these services and try to partner up with some medical professionals to offer HRT, but that's down the road. We're fairly new right now. But when somebody is asking questions about how do I do this, how do I find a doctor, you can send them our way, and we will get them set up with that. Okay, so we want to open it up for Q&A. We had a microphone
to give
person.
away my mic.
Oh, there he is.
Oh, where is he?
Do you need this microphone over here?
Oh, he's behind me?
Okay. No, he's...
Got trolled.
Hi, I'm a well-educated and loud dinosaur.
Okay.
I have a couple of questions.
Sure.
This morning, I saw on TV a woman who wanted her physician to change the sex designation on her birth certificate to non-binary.
Okay.
That confused me because I thought that binary was more a gender identification than a sex identification.
Yeah. So are you asking why that would be allowed, or
Why
how that works?
wouldn't she say, my gender is non-binary, my sex is whatever she chooses to say.
So a lot of times people do pursue on a driver's license, it's called a gender marker change from male to female. On a birth certificate, it's the sex. And they'll do that after legally changing their gender marker on their driver's license because a lot of trans people will run into issues where they are told, well, you have to abide by the rules based on your birth sex. And you have to live in certain ways based on what your birth certificate says. And so a lot of people will pursue that legal change so that they are not being forced to do things based on birth certificate rather than their identity.
But binary or non-binary really refers to gender identification.
So non-binary, the term just refers to rejecting the idea that there are two options. And it could apply to anything. So when we say non-binary, we're saying I'm not going to choose one of these two boxes. Most of the time, non-binary refers to gender. I think most people, when they say I'm non-binary, they're talking about their gender identity. But I know India has now allowed for a third gender, which they also equate to sex. So that might be, and I think California does too, correct?
So
this was in Oklahoma.
Right. So I haven't seen this news article itself, but I guess I can just answer honestly for me. I think sex designations on public documents are grounded of and for an era in which sex was conflated with gender. Therefore, a lot of times when you see sex as a marker or a designator on birth certificate or driver's license, that does not actually truly reflect the intent, which is how do I move through society and how do I carry myself through society? And so gender non-binary reflects a gender identity rather than sex itself. And so you're correct that sex is not the right category to put non-binary into. And so I guess I would have to ask that person what they're trying to do by changing their sex marker there. Is it that they're critiquing a system that puts and conflates sex with gender, or are they critiquing a system in which I need to lead biology first before you see my humanity? And so that's kind of what I suspect is going on there, but I'd kind of have to look at the news article myself.
Yeah, actually it was a TV interview.
Okay.
And sometimes people in interviews become excited and confused. And I thought that probably the person was confusing gender and sex, but I wanted to find out from the experts. The next question is more embarrassing.
Okay.
LGBTQ. I know what LGBT means, but Q confuses me.
It's confusing because it has multiple.
Yeah, so just to break it down pretty quickly, a lot of times nowadays it's LGBTQIA+. So L, lesbian, G, gay, B, bi, LGBTQ, T, trans, sorry, can't forget the trans, Q, that can stand for questioning or queer. It depends on how the individual is identifying. And then I is intersex, and then A is asexual or agender, depending on...
Or ally. Sometimes it's used as ally, although there's
right.
debate over that. But, yeah.
Good
and then
question.
the plus is like everything else.
Yeah. Good question. Thank you. All right. We love that.
Mm-hmm.
Mm-hmm.
I would come at those questions, if it's medically necessary, if it's treatment relevant, I would come at it from a very direct place. Like, hey, this next question I'm going to ask is pretty personal, and here's why I need to know this information. So explaining how it's relevant before asking the question, particularly with things like, have you had any gender-affirming surgeries? Why do I need to know that? Well, I'm about to ask you a question that's personal. I need to know because my medical treatment of you might require this, this, or this, or my prescription of medications, I need to know if there's anything that it's going to interact with. And that is the reason that I'm doing this. So it's basically coming at it from let me prepare them and let them know ahead of time, here's why this is relevant. So it's not coming at them like, why are you asking me? They don't have to ask that question. Does that make sense?
Yeah, and to build off of that, a lot of times when I have like a mandatory referral situation, or I have to do something unpleasant or uncomfortable but required by my licensure, a lot of times I get a good return when I ally myself with my client or patient against the system. And so that would look like doing what Ashley suggested, and then also saying something like, I understand that sometimes people ask you these kinds of things because they want to figure you out and make you fit their boxes. And I know that this situation isn't ideal because you've been asked all this before, and it makes you feel like we're really looking at just this piece of you instead of the whole. You and I, we have to go through this dance together because of X, Y, and Z, like Ashley said, and once we get through this required piece, then we can move towards the other stuff. And so I sometimes really explicitly ally myself with the client or patient against the system and the requirements of the system.
Yeah. So if you, and working in substance abuse treatment, I've run into this where I've had to ask questions that are not necessarily comfortable questions, or that I'm not really, for example, having to ask male or female on sex identification. And I always made a point of saying, there's 2 boxes here, but if you need me to write something else, I can write something else.
Yeah,
To the
exactly.
side.
Yeah, because we have to work within our systems too, sometimes depending on where we're practicing, and we can acknowledge that the system doesn't always work and lags behind, and that can be rapport generating with the client to acknowledge that reality.
Good question.
We got a question over here.
Okay.
Yes. Is there a layman's book, video, or resource that's recommended for instance, a family member that's Christian, cisgender, dealing with a family member that's come out as a bisexual married person or something like that? Is there something that's recent that I can point to them as a resource and say, here, read this, or go watch this video, or what will help them to deal with understanding and avoiding alienation in that,
Right.
in that aspect?
That's a really good question. I don't have a list in front of me, but there are a few that I do know off the top of my head. There are some books that are written from the perspective of parents who identify as Christian and have had children come out to them as LGBTQ, and how they came to terms with that. That's something that I've directed people toward several times. For people who are they don't really understand, there's a book called The Transgender Child for parents of young children, and then there's one called The Transgender Teen, I think, by the same people. It's Stephanie Brill and something Pepper. I don't know exactly, but those 2 are very good because they're laid out in a way that's not super jargony and clinical. It's written for parents to better understand gender identity, gender expansiveness. There's also
Yeah, I was just going to suggest, I always send people to Trevor Project's website because they have different manuals on different things, and they have manuals on things I'm even surprised about, because they have a manual on how to have an intersectional conversation on the intersectional nature of ethnicity with orientation. And so I always send people to Trevor Project. They have a glossary of terms. They have different articles that are all really well written every time I've been there. I donate to them, and I feel like my money is always really well spent with Trevor Project.
GLSEN is also a good one, GLSEN. That's actually where we got our safe space kits for the schools. They have a lot of educational pamphlets and brochures that you can even download and give out to clients or family members. There was another one that I was trying to remember while you were talking.
Is it the Metropolitan Community Church, if it's faith-based?
Oh, yes. So in Wichita Falls, there is a church that is, most of the congregation is LGBTQ. The pastor is trans. That's a really great resource for people in the area who want to maybe talk to a spiritual leader about, like, you know, what does this mean? What does this mean for my faith? Things like that. So I do direct people there. And if there's something like that, if you're not from Wichita Falls and there's something like that in your area, a church that's, I think the metropolitan churches are a lot of times LGBTQ heavy. That's a really good resource, is sending them to those churches. Yeah.
Any other questions? Any non-micers? Hands up. Okay, well, I guess I did want to say before they yank me off stage, because we're running long, I see my handlers over there. I did want to say that I acknowledge that it's literally 5:05 and that we have dozens and dozens of people who cared enough about empowering themselves and doing right by their queer and gender expansive clients that they literally stayed over. And I feel like you guys are the people that Jack probably most needed in that setting, and I'm so glad that you guys are here and really walking that walk of empowering yourselves even past the buzzer. And it makes my heart really glad because it's a difficult fight sometimes, and it's really nice to see that we have allies in really difficult places for people like us and also our clients. So thank you, everybody.
Thank you.